Prova. 1, 2, 3, prova. Si sente? Si sente, Nicola? 1, 2, 3. Prova, prova. 1, 2, 3, prova. Prova. I controlli i vari volumi? No, per capire se sono giusti dal primo in là. Questo è il 3.1, quindi è il primo del mixer. Questo è il 3.1. 1, 2, 3, alza, alza. 1, 2, 3. Ok. Questo è il 3.2. 3.2. Ok. Metti di nuovo volume. 3.2. Ok. Questo è il 5.7. Vai. Ok. Cosa? Questo è il terzo, sì. Questo è il quarto. Ok. Allora, questi invece quindi sono in ordine. Ok. Ok.
Dottore, i cavalieri tutti parlano, no? Ah, ok. Questi non li tirerei qua. Questi sono già nell'ordine di questi. Solo quello, è a posto così. Il bench. No, questi li proponiamo fuori. Che sono anche di poi invece questi quasi si ritrovano perdere anche qualcuno perché loro si trovano fare tutto. No, 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 nel senso Vai. Vai, se non potete questo non va. Ma ci mancherebbe altro, a casa a Roma, a Roma deve da prendere. Va bene, dottore, invece ho una schedina il disco del padre. No. Esatto. Ma ti dato due sono messo osservatore all'ingresso. Aspetta che controllo e dopo ti dico. Non c'era il dottor Polifone. No, perché c'è delle variazioni. La Marianna dove cavolo se n'è andata? È lì libertà. Ma si chiama lo facciale. Ok, perfetto. Ecco, no, io invece conosco le persone veramente importanti. No, io fare un... So calciatore lavoro. Ecco, dottore, ecco, questa lista che viene da Linda Montanari e Liga Duffel, quelli di Taggio sono Scover, Demetrio e Giorgio. Ok. Grazie. Poi la Morazzi in teleconferenza e poi Danilo Cerera viene con Sara Scenti che va a studiare. Va bene. Un caffè ce lo puoi.
Guarda, per accendere i microfoni non ce la fai. Per accendere i microfoni, vedi questo tastino bianco? Sì. Lo tiri verso l'alto con la punta dell'unghia, vedi? Tieni premuto e diventa verde. Questo soltanto per un modo.
Senti, okay. Se lo tiro così prendo la corrente, secondo te?
Che cosa?
Non parlo, scusa.
Cosa dici?
Pezzettino della presa.
Il programma lo proiettiamo quando
ho far togliere.
Tanto Angelo lì bisogna tagliarlo.
No, è perché è fuori.
Allora, lì c'è
in teoria se ne prendo uno non dovrei prendere esatto.
Però lascialo stare, lo facciamo dopo. No, per lavoro, e adesso intanto c'è, se lentezza dipende dalla capacità.
Questo mi serve, lo lasciamo qua.
Sì, lasciarlo alla professoressa. Secondo te per foglio pieno? Per foglio pieno?
Ce l'ha Barbara, no?
Dove l'ho messo?
No, questi sono quelli che ho fatto stampare se vuoi creare maggior contrasto, è importante. Sì. Ma che spegni questa non c'è qua.
Guarda, spegniamola già una. Troppo.
È così che contrasto qua.
Però
quando magari c'è
il problema della slide, Angelo,
decidi tu quando.
Il problema della slide amore non c'è più perché
sì,
sia su YouTube che su. Scusa, perché c'è?
No.
Se l'aveste messa voi.
Però io mi ricordo che c'era una musica di video sopra. Questo qui l'ha fatto
Condividere.
No, giusto. Non possiamo, perché lui poi lavora così.
Devo scaricare il file.
No, scusa, non è pubblicato. La presentazione. Si è spento, non funziona più. Fammi fare dopo. Sì, infatti è stesso. Giusto. Ok, adesso ci abbiamo ora. Però io voglio vedere quanto mi dà più. Qua sotto. Questo è veramente lì. L'altro lo devo dire. Però no. No. Se lo fa così.
Thank you very much.
You are incredibly on time. We are not so used to that.
No. So, you are Daniele.
Okay.
Where was this? Yes, right. Sure. Yeah, I have only with laughs.
How you doing? I don't know.
Yeah, so it's good to meet you. Yeah. Yeah. Yes. Yeah. Yes, right. I only have speech. Yes, I only have speech. So
No slide.
no slides.
Okay, we go.
Thank you. Thank you. Yeah, sure. Absolutely, yeah.
Sono arrivato.
Morning.
Sì. Massimo, cerca. No.
Ah, ok. No, ma nella cartucina. Hai visto?
Non adesso però
Yes, it is. It's very expensive. If I actually walk twice, it's very big. E dopo but I understood that. Yeah. I read about the history. The way you read that. Yeah, it looks like a sweet. That's like I did this morning. Nice to meet you. Hi, nice to meet you.
Yeah?
Yeah.
Roberto told me.
Sure. Yeah. Okay. Yeah. Yeah. So we will. Did you have like mobile systems in the house?
Yes.
Yeah. Yeah, sure. Yeah.
And still we have ormai canale lo schifo di nostro
Le cose che fanno classiche.
Almost on off one year energy, but so now I'm trying to keep time, but
All'inizio un attimo dai. C'è lavorato.
But in this case, we manage.
Buongiorno, mi sentite? No,
La sentiamo, buongiorno.
Ok, apro anche un attimino il video. Mi vedete?
Sì, la vediamo anche. Adesso le chiamo il dottore.
Sì.
E la
Cos'è, alle
vediamo.
9, giusto?
Sì, tra 10 minuti.
Ok.
Buongiorno,
Buongiorno, sono Lucia.
cominciamo fra qualche minuto.
Ok, porto di là l'iPad intanto.
Sai che non la sento?
Dicevo che porto di là il device, che la vicepresidente si collega dall'altro in un altro ufficio.
Va benissimo, sì, intanto noi facciamo entrare tutte le persone, così appena cosa... Bene?
Va bene, grazie mille.
Ce l'ho. Non rischiamo di il modo.
Yeah, the beginning when they it was the house the meeting, the introduction of the yes.
Scusate. Chiedo scusa. Mi sentite?
Dottore, ce l'ha.
Sentite?
Sì, dica.
Volevo avvisare che purtroppo non riesce a collegarsi in diretta la vicepresidente, quindi registra il suo intervento e ve lo mandiamo, cerchiamo di fare il giro di brevissimo, quarto d'ora massimo.
Magari tanto noi ci stiamo ancora, per cui all'esterno intanto faccio parlare qualcun altro. Mi avvisa
Sì,
lei?
certo.
Grazie.
Scusate, ma è successo un imprevisto che non riuscivamo a prevedere.
Va bene, grazie. Allora mi avvisa lei quando...
Sì, a chi lo mando il video?
Dice che registrano e ci mandano il video perché non riesce a parlare in diretta. Come si può dire? Ma lo manda una mail?
Sì?
Se lo manda una mail non riusciamo a... Aspetti un attimo, Allora, lo mandi a questo indirizzo.
E l'alternativa... Ok, mi dica l'indirizzo.
L'alternativa?
Potevo vedere se riesco a condividerlo dall'iPad con Teams.
Diceva di condividerlo via Teams, se no.
Come?
Diceva che quando ho registrato il video si può condividere via Teams come fossero delle slide.
Infatti, provo, speriamo che non sia troppo pesante. Comunque, la mail, che così abbiamo entrambe le opzioni.
Ok, va bene. Diciamo così, è pronto, così ce lo fate... Va bene?
Va bene. Ok, grazie, scusate.
Roberto. Quelle sono tutte che si possono utilizzare. Quelle sono tutte si asciuga.
Hello, can you hear me? Hello? Good morning. Welcome. First of all, welcome to San Vittore. Of course, we will need some minutes to set up everything. We will repeat several times that we are in a prison today, so something will go wrong for sure, okay? We hope nothing dangerous. Just I would like to ask you if you have any presentation to project above all for the first sections in the morning, please give to me that so I can put on this laptop, okay? Thank you. Okay, let's see. You have given a recognizable name to this presentation.
I hope that's another
Sorry. Sorry, I'm sorry.
Final presentation.
Final presentation.
Yeah, no, you don't want that. That's my teaching. Sorry.
Okay. Is it?
Yeah, I think it's that. Oh,
Which one?
Okay, so it's work package 6 one. So it's that one. Oh, God.
Because it's not a PowerPoint presentation.
Oh, really? Just going to talk. Yes. I'm going to have to add live. Yeah.
Okay, this one, which else?
Yes. Today. The one, are we doing the one or two today?
Also the one for tomorrow, if you want. So we have already. Which one? Right, monitoring presentation.
Yeah, all four. There's a 4 presentations.
Okay, we'll put all the 4. Okay.
That's brilliant.
Yeah.
I was going to say.
Chiedo scusa, mi sente? Mi sente?
Sì, chi sta parlando?
Sono Lucia, l'assistente della dottoressa Moratti.
Sì, buongiorno Lucia, sono il dottor Cocco. Allora, dimmi.
Allora, io sto scaricando il video da mandare. Lo
L'incontro.
mando a lei?
Sì, dimmi.
Lo mando a te, quindi il relatore, come sulla chat di Teams?
Lo mandi a me sulla chat di Teams, sì.
O non so chi è che gestisce
Sì, un
la
attimo.
regia.
Sto cercando di capire. Sì, mandalo a me sulla chat di Teams. Ma hai il mio contatto?
Allora, qua vedo che sei come relatore.
Esatto, mandalo al relatore, esatto, sì, sì.
Ok, un secondo che lo sto scaricando,
Perfetto, sì, sì, grazie.
Ok. Va bene. Va bene, ok. Grazie.
Ciao. Okay. So this is for Emma. Okay. What is it? Don't make it. No, you have to use the mouse.
I have a pointer with me if you want it.
I don't know if we can we are able to set up.
No, it doesn't even say.
Okay, you can use just like you are asking if we want to. The problem is that people on Teams they would not see what you are pointing. Just
No problem, but they can think you already have.
Okay. You can leave it. Which one you want? Only this one.
So, may I?
There are not enough.
Okay, so honestly, that's important.
Okay. Yeah, let's see later if because now. Thank you. You are very kind. Thank you. Ammazza.
Questo
Guarda che forse l'aveva spostato il Barbara di là. Guarda, posso staccarlo con la violenza tipica nostra.
Grazie.
Devo condividere il video. Sì, sì, lo sta seguendo anche Mendola. Ok, in 5 to 10 minutes we are going to start. There are some challenges in sharing some videos from the region. The name.
Chiedo scusa, sono riuscita a mandarla nella chat, ma credo di tutti quelli che sono collegati, purtroppo, non solo a lei.
Ora lo controlliamo, grazie.
È un WeTransfer, tipo.
Sì, sì, io sto cercando di scaricarlo.
Ok.
Speriamo di riuscirci. Sono 450 mega adesso. Okay, we are quite stressing the technical capacities of this place, and now I can tell you.
Niente?
Lo stiamo scaricando, ci vorrà... Aspetta, vediamo se c'è una previsione. Secondo me ce la possiamo fare, ci vorrà un 5-10 minuti, ok?
Ok.
Sì, io direi che fra un paio di minuti intanto noi iniziamo e poi non appena riusciamo a proiettare il video lo proiettiamo. Voi l'avete già provato?
Come?
L'avete provato voi?
Sì, sì.
Ok, grazie.
Prego.
Can you hear me? Can you hear? Okay. Good morning to all of you, and also on behalf of my team of the Hospital San Paolo and of the prison of San Vittore, I wish you welcome to Milano and to the prison of San Vittore for attending at the first meeting in presence of the RISE-Vac project. My greeting also goes to those who are connected remotely by Teams or by in streaming by YouTube channel. My particularly greeting and thanks to Lara Artavowski, my co-chairwoman, who shared with me the belief that this meeting could be held within any penitentiary institution to give a message of discussing health problem, health intervention, where the inmates live their detention path. About this, I would like to thank the penitentiary administration for their hospitality and collaboration, particularly during recent COVID epidemic. The program will include a tour of the prison of San Vittore and the most playful time with a lunch, either today, either tomorrow morning, offered by the women inmates. The program will go on tonight with a training meeting and the dinner offered from San Vittore, the restaurant of Bollate Prison. The location is unusual, and is not used to host scientific events of this magnitude, of this relevance. So I apologize in advance for any inconvenience. Me and my team and the prison staff are at your disposal should you have any problem or question. I thank all the authorities, international, regional authorities that are present here today, and I will invite them to give a welcome speech. And the first of all, Madam Martine Ingolsen from European Commission, DG Santé, responsible for COVID vaccination program. I please Martine to take the floor for a welcome speech, and thank you.
Thank you very much. Can you hear me? Yes? Fantastic. Thank you. And I understand now that I have the honor of starting this whole event up. That's super exciting and... Sorry? Okay, of course. Sorry, we've got too used to those masks right now. It's a bit better, right? Thank you. Thank you very much. And as it was just mentioned, I'm Martine Ingvarsen, and I work as a policy officer on vaccination in DG Santé in the European Commission in Luxembourg. And DG Santé, that's, as you know, that's the General Directorate for Health and Food Safety. I'm delighted to be here in Milano at the General Assembly of the RISE-Vac project. Thank you for inviting me. Thank you for having me. As you all know, I'm sure vaccination is a national or a regional responsibility, but the Commission supports member states in achieving or maintaining high vaccination coverage rates. We do this because vaccination is the most and remains the most cost-efficient public health tool at our disposal to prevent infectious disease. And it's also key for what we could call resilient health systems at all levels. And this has become even more clear during the COVID-19 pandemic. It's to a very, very large extent, thanks to vaccination, that we are now entering a more manageable phase of the health crisis, even though we, of course, still need to be vigilant. And still, there are un- or under-vaccinated population groups in Europe. And the RISE-Vac project attempts to reach one of these population groups, namely people in prison. It's a very special project, and the next 2 days General Assembly is taking place in a very special setting, namely a prison. And we're following this project with excitement, but of course not only because of this very special character that it has. I think I said to Lara the other day that you really found a niche here, But and it's almost refreshing, even though it's not fun. But on the other hand, I mean, it's really something new, and it's exciting just because of the setting, basically. But it's of course also exciting and interesting and useful because we need to reach on or under-vaccinated population groups, and reaching people in prison. That's one way of doing this, and while at the same time, of course, increasing the overall vaccination coverage rate, because that's basically a side effect of this, I would say, which is very useful as well. We can maybe say that the rollout of COVID-19 vaccination in member states, when we finally had the vaccines, that was a little bit of an experimentarium in terms of reaching population groups that are usually hard to reach. And as you may remember, the European Commission invited member states to define priority groups for vaccination that should be used as long as vaccine deliveries were scarce, because they were scarce in the beginning. And this is why we ask countries to really figure out in advance, so to whom do you want to give vaccines first? And in our recommendations for this, we included the elderly, people with chronic diseases, and health professionals, of course, but we also included essential workers, that could be prison staff, and we also included communities that are, for one reason or another, unable to physically distance, and that could be people in prison. And together with the European Centre for Disease Prevention and Control, the ECDC in Stockholm, which is really our key partner, we have followed the rollout of COVID-19 vaccination in member states, and we can see that many countries actually did prioritize prison population, both inmates and staff. And many countries also delivered vaccination directly in prisons through mobile vaccination teams or other arrangements like that. And still, people in prison are at risk of being on or under vaccinated. And this applies, of course, not only to COVID-19 vaccination, but to all the other types of vaccination at our disposal, and that we may maybe have forgotten a little bit during COVID, but which are really equally important. And therefore, we in the Commission, we're very interested in discovering the tools, the models, and the approaches that you have and that you have developed already, and that you will be developing in this project. And I look personally very much forward to the next 2 days. The RISE-Vac project is funded by the European Union's health program, and with its focus on reaching a population groups that is usually hard to reach, it really fits nicely into the Commission's work on vaccination. And I would like to say a few words about this. The backbone of the Commission's work on vaccination, that's the Council recommendation on strengthened cooperation against vaccine-preventable diseases from 2018. And based on this Council recommendation, the Commission has launched a large number of initiatives with the common goal of increasing the uptake of vaccination in the European Union. We have, for instance, held a global vaccination summit together with the World Health Organization. We have set up a coalition for vaccination that brings together European health professionals and student associations to advocate for vaccination. And we have launched the European Vaccination Information Portal, where people can find accurate information about vaccination. And this is super important because we're all aware of all the mis and disinformation that is flying around out there. But in the Council recommendation, the Council also welcomed the Commission's intent to, and here I quote, to identify barriers to access and support interventions to increase access to vaccination for disadvantaged and socially excluded groups in line with national recommendations. And with its focus on reaching people in prison with vaccination, this is precisely what the RISE-Vac project is doing. And in this way, the project helps the Commission to implement the actions in the Council recommendation. But since the Council recommendation was adopted in 2018, we had the COVID-19 pandemic, and the Commission moves on with its work on vaccination, but now, of course, taking this huge experience into account. And most importantly, we have launched a new EU for Health program, and there are also initiatives about vaccination in that program. We have, for instance, a project about how to reduce physical obstacles to vaccination. This is a project which I personally look very much forward to. And it's also a project where I could definitely imagine synergies with the RISE-Vac projects and other projects like that. You may also have heard about it's called the Europe's Beating Cancer Plan. Normally we just call it the Cancer Plan, but there we also have projects about vaccination. We will, for instance, launch a proposal for a council recommendation on vaccine-preventable cancers, and that will in particular address the cancers that can be caused by human papillomaviruses and hepatitis B virus. We also just launched our proposal for a European health data space, which will support the, smart exchange of health data, including data on vaccination across Europe. So there are exciting times ahead, and we look forward to following all these things, but then today, of course, particularly the RISE-Vac project, which is one contribution to one common goal, which is to increase the uptake of vaccination in the European Union. Thank you.
Thank you, Martin, for your authoritative intervention. And we'll try to launch the...
Okay, let's see
our Councillor for Welfare, Letizia Moratti, recorded a message for our meeting.
Finger crossed.
I would remind that our councillor is particularly engaged in social fragility and particularly on PWID health interventions. And so her message is very, very important for us. Suspense.
Non so l'audio, se l'audio da dove si sentirà non lo so, quello...
No, proviamo.
Okay. Sto cercando di farlo partire, vediamo. Che c'ho questo. Non si sente l'audio. Tra l'altro, scusami, lo dovremmo proiettare anche qua.
Non si sente.
Però l'audio si sente qua, ma sono...
Non ci sono troppo. Vieni, se no.
Se sei dove, come vedere? Ah, lo mandano loro, guarda, lo mandano loro. Okay. Se fate... Sì, ok.
Ah.
Lo mandano loro direttamente. Scusate, sorry for the delay. Sì, dovrebbero proiettarlo adesso. Sì.
Ah.
Sì.
Okay. In the meantime, we go on with the speakers, and I'm socio-sanitary manager of San Paolo Hospital, Dr. Giorgio Cattaneo. I know that he prefers to speak in Italian, but Nicola Cocco will summarize us his speech. Please.
Sì, buongiorno a tutti. Grazie di essere qui. Io, come ha detto il dottor Ranieri, contribuisco alla direzione sociosanitaria dell'azienda sanitaria Santi Paolo e Carlo, che ha la gestione di tutta l'attività sanitaria all'interno degli istituti penitenziari milanesi. Quindi San Vittore, che è dove ci troviamo, la casa di reclusione di Opera, quella di Bollate e quella l'istituto minore per penale minorile Beccaria.
Okay, Dr. Cattaneo is presenting himself, telling that he is participating in the directorate of San Paolo Hospital Penitentiary Medicine, that is dealing with all the main prison in Milano, Bollate, Opera, San Vittore, and also the young people prison of Beccaria.
Come ben immaginate, la gestione dell'attività sanitaria all'interno degli istituti penitenziari è molto complessa. È complesso il sistema carcerario, per cui occorre che tutti gli elementi, tutte le componenti che in qualche modo lavorano all'interno degli istituti penitenziari collaborino fattivamente tra di loro. È complessa la popolazione carceraria, è complesso il rapporto che la popolazione carceraria ha con le istituzioni sanitarie. Spesso questo rapporto nasce su presupposti che non sono di salute, ma sono magari legati ad altri fattori, e quando invece il rapporto è appropriatamente basato su problematiche di salute, subentrano componenti di tipo culturale, sociale, di dipendenza, che in qualche modo rendono molto complesso il rapporto e necessitano da parte dell'istituzione la presa in carico globale del paziente, del detenuto.
You can imagine how complex can be the dealing with this environment of prison, and this is much more complex when we are dealing with health problems, when you need also to give a perspective that is cultural, psychological, and trying to put at the center the prisoner itself, the inmate himself.
Per dirla con una battuta, il carcere fa male alla salute. In carcere è difficile adottare degli stili di vita sani come si raccomanda alla popolazione generale, e oltre a questo c'è poi una promiscuità e a volte anche un sovraffollamento che facilita ovviamente quella che è la diffusione di malattie di tipo infettivo. Proprio per questo la nostra organizzazione prevede un'equipe di infettivologi che si occupa proprio della prevenzione di queste malattie. Vengono attuati appunto screening sui detenuti per quanto riguarda l'epatite, l'HIV, la TBC, le malattie sessualmente trasmesse, e da ultimo ovviamente anche per quanto riguarda il Covid.
Okay, of course, in a joke we can say that a prison can be harmful to health of people. And it's one of these reasons that bring San Paolo Hospital to have a very well-equipped team of infectious disease doctors working in prison and dealing with the main infectious diseases like HBV, HCV, HIV, and tuberculosis. And of course, vaccination are part of this contest.
Oltre all'attività di screening, poi vengono effettuate anche le attività terapeutiche nei confronti dei pazienti che hanno appunto queste tipologie di malattie. Pensiamo ad esempio allo screening e alla terapia dei pazienti HCV positivi piuttosto che agli HIV positivi, e con la recente pandemia anche l'assistenza ai pazienti portatori di Covid. L'istituto in cui ci troviamo e l'istituto di Bollate sono diventati durante la pandemia un hub Covid in cui sono stati concentrati e trattati detenuti praticamente in tutta la regione Lombardia, e sin dalla fase di esordio della pandemia, quando ancora non si aveva a disposizione la vaccinazione ma semplicemente gli strumenti di prevenzione, si è riusciti, grazie alla nostra equipe e alla collaborazione con tutte le componenti che operano in carcere, a contenere l'epidemia entro limiti più che accettabili, e una volta a disposizione il vaccino, la somministrazione del vaccino ha consentito di raggiungere livelli di copertura nettamente più significativi rispetto a quella della popolazione generale.
Of course, dealing with these diseases is not just a matter of screening, but a matter of managing of the disease, also taking care of treatment and follow-up. And this is very true for all the infectious diseases we were talking about. And also the pandemic of COVID-19 has been a very important example of dealing with infectious diseases. San Vittore Prison House and Bollate Prison have become a real COVID hub for all the detainees in the Lombardy region, and this was very meaningful both in terms of containing the spreading of the disease and in terms of vaccination. Vaccination rate in prison were also higher than in a general population in Italy.
La vaccinazione è sempre stata uno dei capisaldi della nostra organizzazione. È stato istituito fin dal 2018 un ambulatorio vaccinale presso la casa di reclusione di Opera e avevamo in programma di istituirlo anche qui presso San Vittore, per cui ci si sposa tranquillamente, cioè la nostra strategia va esattamente nella direzione e si incrocia con quello che è l'obiettivo dei lavori della giornata di oggi.
Vaccination is a paramount aspect of our activity in this prison. Already in Opera Prison there is a vaccination clinic inside the prison, and we are going also to spread these kind of activities, and all these aspects are very well related to what we are going to discuss together today.
Il nostro obiettivo è quello di arrivare ad avere una sorta di calendario vaccinale obbligatorio per quanto riguarda le persone detenute, che vada a coprire quelle che sono ovviamente le patologie più diffuse all'interno degli istituti penitenziari, ma agire in un modo che sia permeabile con l'esterno, nel senso di utilizzare gli stessi strumenti di lavoro e di registrazione che si usano negli ambulatori aperti, negli ambulatori che operano sul territorio. Riteniamo che sia opportuno che ci sia una permeabilità tra il sistema sanitario penitenziario e quello territoriale. Questo perché spesso capita che i detenuti entrano in contatto per la prima volta col sistema sanitario proprio al momento della carcerazione. E limitare l'intervento al solo periodo della detenzione è ovviamente limitante per il lavoro che svolgiamo noi, è limitante per quanto riguarda i benefici della persona ed è limitante anche per quanto riguarda i benefici della società. E riuscire a mantenere una permeabilità tra il sistema sanitario penitenziario e quello territoriale consente anche alla società di avere individui più sani in circolazione.
Actually, our main aim is to have a very well shared and targeted scheduled vaccination for all the prison. But this is not enough, because the main challenge is to open the prison, to make them porous and permeable to the territory and to society. Our idea is to build a system that is creating a share with the territory for people that are in prison and then they are released, so that this kind of schedule is well respected and also homogeneous with what is already done in the territory medicine.
Io credo che la permeabilità, oltre che dei sistemi sanitari tra territorio e istituti penitenziari, debba estendersi anche ad altri settori, tipo quello della cultura, tipo quello dell'informazione, delle idee. Il fatto oggi di essere qui in istituto penitenziario va in questa direzione. Mi piace ricordare in questa sede che solo qualche settimana fa ho assistito proprio qui a San Vittore a un concerto aperto al pubblico dove si è esibito il coro della nave. La nave è il nostro reparto di trattamentale e il fatto di aprire gli istituti all'esterno è sicuramente una cosa che contribuisce da un lato a migliorare l'attività all'interno degli istituti e da un lato anche a far conoscere all'esterno quello che viene fatto all'interno del carcere. Io credo che questa sia la direzione in cui dobbiamo muoverci e di questo sono grato alla direzione dell'Istituto San Vittore. Mi dispiace che oggi non sia qui il dottor Siciliano, ma mi dicono che vi raggiungerà più tardi. per cui io a questo punto non ho più altro da dirvi, vi saluto di nuovo, vi auguro buon lavoro e buon proseguimento della giornata.
Dr. Cattaneo is greeting all of you, telling that this permeability concept is not just a matter of health, it's also a cultural matter to have a prison open to society. He was just telling the example of the chorus of La Nave World that was participating to a public concert one of the last evening in Milano. So this kind of activities are very important to have a new vision of prison inside the society. He is greeting you again and thank you.
Grazie al dottor Cocco per la traduzione.
Thank you, Dr. Thank you, Dr. Tam. We're trying again to launch Madam Moratti.
Let's try again.
Riusciamo
a farlo partire anche qua? Ok. Sì. L'ho tolto,
Good morning to you all, and thank you for inviting me to be with you for the opening meeting of the RISE-Vac project.
Cosa devo far vedere? Scusami, per farlo vedere di qua. Sì. L'ho tolta la condivisione.
Adesso che era iniziato.
Lo interrompo di nuovo. Non è attaccato. Togliere Teams.
Come c'è scritto là?
Solo sul prossimo. Facciamo vedere solo su quello. Condividere il testo. Condividere il testo. Condividere il testo.
Ma si deve vedere qua.
Ok. Fatelo partire da presentazioni così legano. Sì, sì, sì. Fai partire. Fallo partire.
It is a real pleasure to be part of this important international cultural initiative hosted by Regione Lombardia's San Vittore Penitentiary.
Ok, sorry, we are going to share. Aspetta un attimo, scusa, fallo ripartire. We are going to share the message of Madame Moratti only on that screen. Sorry, but there are some technical.
To you all, and thank you for inviting me to be with you.
And now I'm inviting Danilo Cereda, responsible for the Department of Prevention of Region Lombardy, to have his speech. Danilo, thank you for coming.
Dobbiamo proiettare adesso. Scusa, lasciami
no. Posso usare sì. Okay. Good morning. Thank you for the invitation. I'm Danilo Cereda. I work in Lombardy region. I'm the director of prevention unit. The aim of my presentation is sorry, Matt. Okay. Okay. Is to explain how we want to work for the hard-to-reach people together with SST Santi Paolo and together with the whole regional health system. The Lombardy region has 10 million inhabitants and it ranks second for highest per capita gross domestic product in the nation. Furthermore, the Lombardy is the second ranked region in the center and north of Italy for a wealth distribution gap. Lombardy has the highest number of migrants in absolute value. And from this, we know that the determinants of health, access to service, environment, behaviors are linked to many infectious diseases. And this is strongly supported by literature and practice. So, starting from this, in February, we approved a regional plan, the regional prevention plan for the promotion of health and the prevention of diseases. In this plan, that is a planning tool to establish objectives, strategies, and action to be undertaken for the promotion of health and prevention of diseases based on the regional epidemiological context. The program approach consists of a series of interrelated and current action useful for achieving the macro objectives establishing the national plan of prevention. In this regional plan, we have improved on many chapters, and one of these is dedicated to hard-to-reach people. That the chapter we living condition and social economic conditions. In these chapters, we speak about the data of Lombardy region, and we start to plan how to work in the next years to help to all the system to work with the structure that work with the hard-to-reach people. We know this is because we know that the transmission of many infectious disease, hepatitis C, virus, tuberculosis, HIV, and are strictly connected with how and where people live. The population, we know that this kind of population are homeless, migrants, and inmates. And it's difficult intercepting the health need of these three categories because of cultural, economic, social barriers. The access of the regional health system for this population should occur through targeted action, sometimes even local ones. The meeting of today is one of these actions. We want to start to construct an alliance with this kind of setting and to work together. And this is about all infectious disease, but about preventable vaccine, preventable infectious disease, because we know that we can offer all kind of vaccines that they need. Access to prevention and vaccination and their characteristics are an important factor in ensuring the prevention of vaccine preventable infectious disease. And for this, we know that we start to work together, and we are starting to work with Roberto Ranieri in this month, and not only about vaccination, we are working about other settings, for example, screening of HCV. We are starting in this day too, and we are starting about how to eat in a setting like this, and so we are starting many action to work and to start to have a way to work that is help to find how to reach people. Thank you very much for.
Thank you, Danilo. I warm thank all the authorities, and I invite them to stay compatibly with their agenda. And I would like to remind you to ask all the speakers of the chairman to strictly respect the times assigned for their session, to ease the organizational needs of the meeting and of the prison institution. And then I give the floor to Lara, to the emotion. Our boss. I forgot. Ruggero Giuliani. Is the real life. The health manager of prison of San Vittore, Ruggero Giuliani, an infectious disease specialist, and a distinguished member of the team.
No, sorry, I thought just for time being, but I will make it short. Thank you, colleagues, for being here. Yeah, I'm really proud what Roberto and Lara managed to organize and to have all of you here. It really means it's really a sign, a concrete sign. And we really need concrete sign at this time, also to restart after the COVID. San Vittore prison, as you have seen, is located in the center of Milan. And this is already peculiar for a prison. Now, in the recent decades, all the prisons were built far away from the city, to keep them as far as we can, from the people, from our community. So in this sense, San Vittore is different, is located in the center and is part, of the community of Milan. So people from Milan, they are really somehow attached to San Vittore, as part of the landscape, is part of the life of the city. And this used to, so the one of the advantage of this location is also, that the easy access, for the community, for the volunteers to come. And San Vittore has been always rich in this, We have always enjoyed a lot of volunteers coming inside the prison to help. And this is, I think, is a mark of San Vittore. And as was said before, it's not only, you know, for the health aspect, but also for the cultural and the social aspect, you know to make prison open to the society. We are not, and this is something, you know, that I always try in my mandate, you know, to stress. We are not something separate, you know, from the society. Our health system, you know, should be integrated, you know, in the health system. But we see that sometimes the reality is not like always like this. We always, we often, you know, suffer kind of discrimination also as health worker, you know, compared with you know, when I send a patient to the hospital, they always say, your patient, we send you back your patient. Like, you know, there is a clear division, what is hospital patient and prison patient, you know, and this is something, you know, that make me suffer, and I'm always fight, you know, to reduce and to change this mindset. And also prison health is something, as we have shown during the COVID, you know, can be an example of good health system. And we can also, you know, I mean, I want to affirm again here the dignity of working in prison is not only, you know, medical professional, but is also a humanitarian work what we are doing. We are serving the most vulnerable and the most neglected people in our society. So this is a mandate that I'm proud, and I think we can join. We are all proud of this medicine and of what we are doing. Unfortunately, during COVID time, you know, all this division between community and prison, you know, somehow, you know, increased. You know, all the volunteer with the lockdown disappeared, and the prison remained empty with the worker and with the inmate inside. You know, it was really a dramatic moment that started with the riot, something also that we didn't experience since long time. And this also was, you know, a shocking moment in our experience, and was the beginning of the COVID. You know, was the day, I remember, was the day that lockdown in Italy was declared. We had the riot inside. And so together with the, you know, the fear of the virus, of the pandemic, mixed with the fear of the riot. The riot, you know, was shocking because, yes, we didn't experience, so nobody has a, you know, practical experience of this situation. It was also the moment that we, you know, all the COVID rule that we managed to establish, you know, was completely, you know, forgot for one day. We had more serious problem. We have to treat patients, you know, that were intoxicated by, they managed to get access to medicines, and they get intoxicated by drugs. There was smoke, there was fire, you know, we were, but this somehow, you know, make us united. You know, it was the moment where we feel all together, you know, staff, custodial staff, prisoner, you know, say we are all in the same boat. The virus will not make difference among us. And this is where the moment where we manage to really, you know, to say, okay, we can do it. We can survive to this pandemic. And in fact, we had 1, 2, 3, 4th wave inside the prison, but we managed to create good containment measure from one side and to give access to treatment to the inmate. More than 600 positive COVID patients passed through San Vittore, and we get them access to experimental treatment that was available during the different phase of the pandemic, and we managed to review all the containment measure within the prison that reduce all the you know, the transmission inside the prison and the number of people who got sick and infected by COVID. We always say that the last word is for our patient, the inmate that stay here inside. We say that what we see here I mean, are not, you know, like tremendous or evil criminals. We see poor people inside, and we see people that are excluded from healthcare, from access to care. Not only inside, but also when they were outside. We saw it during COVID vaccination, you know, that when the coverage was very high among the general population, we still have a lot of people entering and that were not vaccinated. So this is just an example, you know, and what is the exclusion to care. And that there is a continuity among the vulnerability and exclusion outside in the society and the arrival inside of the prison. A lot of migrants, a lot of people who experience really suffering, not only escaping from wars, from, you know, the migration route through the Balkans, through Libya, you know, all these people, the most fragile, the most vulnerable arrive here, you know. So the excluded people in the society, they end up in prison. And so, yeah, we have people who have committed crime. We are not saying, we are not denying this, but yeah, I think there are people that somehow, you know, need to restart a new life. And this is, for me, I think, is the big challenge, you know, and somehow a dream or an idealism, no? You know, that the prison can be a moment, you know, as say, not only for punishment, but, you know, also for rehabilitation. And this, I think, is and the rehabilitation pass through, you know, the taking care of themselves, you know, and to taking care of their own health. Okay, and this is our role inside, you know, is the care and the treatment of the people is an important step, you know, for a path that hopefully go for rehabilitation. Unfortunately, I mean, too often we still see people, you know, that I say a revolving door, you know, they're going in and then out and then come again, you know, like in an endless, you know, deathly circles, you know, that is, so I think, what is the role of the health on this? I think we need to think our role as a physician, as a health worker, a bit broadly, not only, you know, providing, you know, consultation, medication, but, you know, providing, you know, also, you know, making our patient, you know, to feel the ownership of their health and to use, you know, the treatment and the care they can receive inside as a step that hopefully they'll bring them outside you know, for a better future, I would say. Is a big challenge. Yeah, I admit, even as an idealist person like me, you know, sometimes I feel hopeless. But I think this type of moment that bring us all together, you know, are the things that make me look forward with, you know, more hope. And we really, I hope, you know, that with the contribution of this project, we'll able, you know, to contaminate it, to create a critical mass, you know, that can change also the role of the prison, not only here, but in all our countries. Thank you very much.
Thank you, Roger, also for the message you gave. And again, Lara, and apologize.
Good morning, everyone. Thank you, Roberto. It's my great pleasure to be here and to see all of you in here with me today. It was possible in the end. So after 1 year trying to meet face to face for this project, now we are all hosted by Roberto, which I'd really like to thank, and all the team for organizing the opportunity to hold this meeting in prison. I'm also a little bit emotional. So I would like to welcome, in particular, all the members of the Scientific Advisory Board who, were willing to spend 2 days of the busy agenda with us today, and also Martin from the DG Sante. Also, I'd like to welcome all our project team members. We are lucky enough to have all partners represented here today. I mean, some are a little bit delayed, but will be here during the morning. So I think it's very important to be united and in presence to exchange ideas and views from different countries. We are 6 countries in the consortium. I think this is a very good starting point when it comes to sharing experiences and models of care in prison. We heard some already keywords from our speakers before me. I think they have already canvassed the content of the coming 2 days. So we heard about prison staff and prison people living in prison, which are the 2 key populations that we look at through RISE-Vac. We also heard about increasing vaccination as an opportunity to improve health of people that live in prison. We also heard about continuity of care and benefit for individual and the general population as well. So I think we have all the keywords already been mentioned from our speakers. I'd like now to bring you to the program, and we have 2 very, very busy days, I would say. But we have tried to organize the agenda of the meeting, the content, in a way to engage already many of you with an active role through the 2 days. And this was done on purpose because we really like to have a collaborative and exchange views and ideas. So I'd really like to encourage all of you to be actively part of these 2 days and bring very much what you have experienced or what are your views, and especially depending on the different countries' context and situations that we have represented here today. We also try to interwoven the project activities with existing experience and initiatives at national and international level. And this again was done to explore synergies and opportunities for this project to interact and build upon what is already happening and possibly provide some basis for future activities. So this is a niche, I agree, but it's a niche with great potential, and I think we will try to explore this together. Before I lead you through the program, I'd like to remind you that this meeting is recorded, so we have a YouTube channel and we are live. So this, of course, is for you to know. I think it's important, but also in case you'd like to showcase and call back what has happened during these 2 days, this will be available in future. Also for dissemination possibilities or opportunities. So going back to the program, we have, as I said, 2 very busy days, and we have full sessions like this one, but we also have working groups where we'd like to engage a little bit more in active exchange. We've organized the meeting starting with 2 of the key areas of project activities. So one is about vaccine literacy and information education in prison, targeting people living in prison as well as prison staff. So this will be the first session. Then we will move to the other areas, which is that of vaccine offer and vaccine availability in prison. And here particularly we would like to start from what has happened during COVID-19. So we know all countries that are in this project managed to provide universal access to vaccination, including for people in prison during the past 2 years. So this is a very good starting point to improve the situation also for the other vaccines that are relevant, of course, for the prison population. Then we will we'll have the chance to taste food prepared by women in prison in San Vittore, as Roberto mentioned. And then in the afternoon, we will have these group activities. So we've tried to allocate all of you in different groups. Of course, if you're not happy with the allocation, you may change. This is absolutely fine. Actually, we would have liked to have all of you in all groups, in fact, but this was not possible. So please bear with us for making choices. Then the afternoon will end with a dissemination activity. So Roberto has been forward-looking as to manage to invite a journalist from Corriere della Sera, which is one of the main Italian newspapers. So she will lead us through an open discussion from which we hope will come some important dissemination output. And then we will not let you go, as we will have a dinner in a different prison in Milan, which is Bollate. And again, the dinner will be organized by people living in prison. We know that this can be quite an intense day, but we thought it was just an occasion to guide you through different, let's say, experiences in this setting. And then tomorrow we will start again 9, and we will have, let's say, another important chunk of work to discuss, including feedback coming from the working group, which will be the sort of the study, or the the observational study that we plan to implement through this project. So it will be let's say, more technical discussion around how can we measure what the project will manage to achieve, meaning increase in vaccine literacy and increase in vaccine uptake in prisons. So we would like to come not only with models and materials such as educational material, but we would also like to come with a measurement of what is in fact possible to achieve in prison. Then we will have additional sessions on, particularly on monitoring, internal monitoring activities of the project, as well as dissemination. And then we will end our 2 days with another nice lunch in here. So thank you very much again for being with us, and I wish you a good meeting. Thank you.
The chair of the next session.
Okay. Good morning, everyone. Buongiorno a tutti. Thank you, Lara. Thank you, Roberto, and the prison here for welcoming us. Is it okay? Yeah? So, we are going to co-chair this the round table. This session on improving vaccine literacy, tailored interventions for prison population and prison staff. First of all, I would like to tell you who I am. I'm Josefina Mavro. I'm coming from Cyprus. I'm working at the National Focal Point in Cyprus. I'm a sociologist, and I have a background on drug addictions in social education. Please.
Good morning also from my side. I'm Jörg Pont. I'm a medical doctor, a former prison doctor, and allow me to say, listening to Dr. Giuliani's speech, my feeling was you were really speaking out of my heart. Thank you very much for this very clear view you gave us. I said I'm a former prison doctor. I'm working now as a free consultant, particularly for the Council of Europe, and I'm excited that we are allowed to lead this session. The session, as you know, is called Improving Vaccine Literacy, Tailored Intervention for Prison Population and Prison Staff. And my understanding of tailored is it should be tailored in a way so that the target population feels empowered, that the target population finally can get a feeling of ownership to the project, or it's also characterized by the saying, nothing about us, but everything with us. So this is for me the understanding of tailored.
Okay, if we may start with our first speaker, Emma Clark.
The first is Barbara Muslim.
Yeah, but they have changed it.
Okay.
Yeah. Emma Plug is a senior research fellow in the Health and Justice team from the UK Health Security Agency.
I don't think this is the one that's working. I think this is the one.
Ho bisogno di aprire una presentazione però.
It's not going to work, is it?
No.
If it doesn't, I'll just chat.
No. Devo aprire una presentazione. Com'è? Ma non mi fa fare nulla perché... Non mi fa fare nulla perché lo controllate voi.
I can just say something if it's easier because we're running thing to keep us up time, because I know
Just a second, because it's a pity.
So in order to save time, if they can't find the slides.
Okay.
Maybe we can go to... Which one is...
good question. Oh God. I think it's the one up.
This one?
Yeah.
Lara, can I say something? The colleagues from Cyprus, from the prison department are here, but I think they don't know how to enter. Yes, I just received a message, sorry. Thank you so much.
I think
It's...
Are
they...
Okay.
Oh,
good, it works.
it's working. It is working.
Yeah?
Can I use the thingy as well to move it? Is that... Nicola, is that...
Yes.
Yeah, that goes all that. Oh, brilliant. Okay. No, that's fantastic. Hi.
Okay.
Right, I have got one. It is working. Sorry, I thought earlier that actually this is going to annoy me, so I'll take it up. Yeah. Right. Okay. Thank you. I'm going to make this quick, but thank you very much. It's a real pleasure to be here. And so thank you for all. I really appreciate all the hard work that's gone into creating today. Have I got to speak up? No, okay. Right. So I'm just going to quickly give you an outline of Work Package 6. This is something that's led by, can you hear now? Do I need to be nearer? Is that me? Can you hear now? Is that better? Okay. Right. So Work Package 6, there are two leaders of this. The first is the UK Health Security Agency, who I work for, and the other is Frankfurt University. So I'm here today from the UK HSA. We have Heino and Babak from Frankfurt, so that's very exciting. I'm going to give you a quick rundown of what we're planning. This is a work stream that really hasn't quite started yet. We've established or are establishing our reference groups. but the meat of the work, what's really happening, has yet to take shape. But that's good, because everybody can inform what's happening today. So, okay, so just to remind you, we're increasing vaccine literacy for healthcare and custodial staff, and for the people living in prison. We have 2 deliverables, and so it's important to be clear on these 2 things that are essentially the end product. The first one is an e-learning course for vaccination in prisons, targeting staff. With prison staff, if I refer to prison staff, I mean both custodial and healthcare. We also want to prepare materials for the people living in prison. And at the moment, what we said we do is written materials and a short video as well. This may change. That's the minimum, shall we say, at this stage. So we have 2 milestones, and that was last month, and that was the establishment of our reference groups, one for staff and one for the people living in prison. We have, you'll see we've largely done that, but I think our reference groups are probably better termed as a work in progress. Okay, so having reminded you of the key outputs, let's just have a look about what our planning is at the moment. So, rather bright colours, but these are RISE-Vac colours. This is what we've done. We've developed our project plan. We've met with our partners, and we've essentially established, oh, thank you. We have the full force of the pink, the reference groups. And just to be clear, what we've said, who would be in the reference groups? So the reference groups will include representation from prison staff, experts in vaccination and prisons, people with lived experience of prisons with whom staff will be working. So exactly what are we going to do? So remember, for the staff, thinking for the staff, we've got this, our final product is by month 24, so that's April next year. So we've got another 11 months in which to do this. So we're going to have a busy 11 months. So we've got our reference group. We have our working group as well, which is essentially the lead partners. And again, we'll be bringing people on board, but they're the people who are going to be putting it together. We're looking at going to be looking at the background information. Babak is going to talk more about that later. Maybe the most important thing here is agreeing the intended learning outcomes. Okay, we have to be really clear. What is it that staff need to know? And actually, is it the same for healthcare staff as prison staff? Is it the same in England, for example, as it might be in Germany? So actually getting agreement is really important. So when we understand and really know what we want to deliver, what we need, what is needed, then we can actually start to think through, okay, in order to get there, how are we going to do that? So how long does this course need to be? How interactive does it need to be? And all those sorts of questions. We are aiming to get the beta version, if you like, of the course online by month 22. So that is February next year. We will then get further input into it before it's actually up, running and ready to go in a year's time. Very different when we look at people living in prison. We're actually handing, or we'll be commissioning out the work there to people with experience of imprisonment. And it's actually, we're going to be working very closely with the Prison Reform Trust, which is an NGO in the UK, who not only have extensive networks into prison so that they can communicate with people who are in prison right now, but have a network of people who work for them, who will be working on this material. This isn't the first time they will have done teaching and training materials at all. They're actually very experienced in this. It's one of the first times they're working on vaccination, but essentially, I think it comes back to Jorg's point about what do tailored interventions mean, and so actually it's about empowering these people and ensuring that it actually meets their needs. And I'm very looking forward to the presentation or the talk in a couple of speakers' time. So then obviously one of the key things is translation into relevant languages and marketing it there and people, letting people know that actually we have these two fantastic courses or two sets of fantastic resources out there. And that will tie in very nicely with our dissemination stream, work package 2. Yeah, and of course, there's no point doing the course and then not evaluating it, not understanding it, and where we could do better. So we'll be doing that in the following months after it's first launched. Yep, and then we have to write it up. But that, in essence, is what we're going to be doing in this work package. And I will leave it there. Thank you.
Thank you, Emma. Now we will move on with Babak. He's a research fellow at the Frankfurt University of Applied Sciences.
Thank you so much. Thank you, Emma. Well, is everything fine? Can I continue or just? Okay. Well, thank you. I'm so excited to be here after 2.5 years without any face-to-face meetings. My name is Babak Moasen. As Josephina said, I'm working at the moment with Frankfurt University of Applied Sciences together with my boss, Professor Heine Stufa, who will be with us today with a little bit of delay due to cancellation of his flight. I'm presenting results of our scoping review on behalf of the scoping review team, Laura Tavoski, Emma Plagi, Sara Mazzili, Nasrul Ismail, and Nasrin Akbaria. Well, most of you are, I mean, almost all of you are experts in the field of prison health. I don't want to take much of your time with a lot of background information, just very briefly to share with you results of, part of the results of my PhD that I defended last year. Well, we estimated that prevalence of hepatitis B in prisons in the European Union countries is at the moment 2.59%. And if you compare that with the results with the estimation of ECDC among general population of the EU, that was 6 per 100,000 general population, you will realize that hepatitis B is over 400-fold more prevalent in prisons compared to the general population of the EU. And that's important, particularly because that's important for us in this project because hepatitis B is a vaccine-preventable disease. Again, I don't want to go through this in detail because we have already presented results of, the aims and also methodology of the systematic review in the previous General Assembly meeting online. Just very brief reminder is that our aims were to first collate and critically appraise evidence on availability and models of delivery of vaccines in prisons, and second, on interventions to increase vaccine uptake in prisons. We collected your feedbacks. Thank you so much. We revised the protocol and started a data collection by searching 5 peer-reviewed literature databases, including PubMed, ISI Web of Science, Cochrane Library, Science Direct, and EBSCO. We also searched gray literature databases, including WHO, WHO Europe, CDC, ECDC, UNODC, Google, Google Scholar, Prison Studies, ResearchGate, and so on. We also posted a call for data on some online platforms like LinkedIn, for example, Webfriend, Twitter, thanks to Alicia. Alicia is not here. And apart from that, we also asked the advisory board and consortium members of the project to provide us with any relevant data. The process of screening was done by myself and my colleague, Nasrin Akbaria. You can see that, well, or maybe not, it's too small. Well, we have 2 tables in our data extraction sheet. The first one on worldwide availability and model of vaccine delivery, and the second one interventions. I will give you information on these data, but not for all of the data, but actually for some of them. This is a preliminary results of our scoping review, and well, we identified, I think, around 3,000 documents in general. After removing duplicates, it was 2,600. And we reviewed 236 abstracts and 120 full texts. And so far, we have extracted data from 30 full texts. And I will be presenting the results from these 30. And the process is still ongoing. Part A, sorry for that, availability and models of vaccine delivery in prisons. So, we found data from 26 publications about this topic. And these 26 publications cover data from 2003 to 2021. And interestingly, most of these publications come from the US, 13 in a specific, followed by Europe, 10 publications, and 3 whole other countries and regions. In terms of scope, well, only 2 publications reported data at regional level, 5 at national level, and all others at subnational levels. And type of publications, well, majority of them, 15 publications, they were reporting data. I mean, in terms of type, they were original articles followed by 4 brief reports, letter to the editors, 3, and again 4 other types of publications. If I have time, I will talk a little bit about that later. 11 publications reported data on prisons, 5 on jails, 3 on a combination of settings, and 7 on other types of settings. Target populations in majority of these publications was people who live in prisons, in 15 publications. 1 specifically on staff members, 7 on both staff members and people who live in prisons, and we also found 3 publications that it was not 100% clear to us if the sample size is only people who live in prisons or both staff members and people who live in prisons. And again, interestingly, 10 publications out of these 26, they were reporting data on COVID-19. And only one on hepatitis A, 3 on hepatitis B, 4 on HPV, 2 on measles, 3 on flu, 1 on varicella, and more than 1 in 2 publications. And it's also interesting to, just to remind you that our data collection was covering publications from 2012 to 2022. And we already know that COVID vaccine is developed and rolled out more or less everywhere from December 2020. So in this short period of time, most of these publications are focusing on COVID-19. In terms of coverage, coverage was reported by 7 publications. It varies widely between 3 to 100%, with a considerably higher coverage among prison staff members compared to people who live in prisons. And in terms of uptake, it was reported by 16 publications, much more this time, and also varies widely between 0 to 95.5%, but we didn't see, so far we haven't seen any difference in terms of people who live in prisons or staff members. Well, it's also interesting for you to know that this 95.5%, it basically refers to people who live in prisons. That was a study on flu vaccine, and these are this uptake was among people who live in prisons. And effectiveness, we have effectiveness reported by 3 publications, but we believe that it's not a true effectiveness of vaccination. If I have time, I will tell you why not. And because, well, very briefly, because first, you need a pre-post design to evaluate effectiveness. And this is in these 3 publications, we didn't have this type of a study. Determinants of vaccine uptake. It has 2 sections. First, results from the statistical analysis. We found that health literacy was one of the determinants. Availability of vaccine, preferences of people living in prisons, cues to action, which most of you may know is a component of the health belief model. Higher age, gender, being previously infected with the target disease, number of medical conditions associated with the infection. And we also found some studies kind of assessing the intention of people in prisons very qualitatively. And based on them, if vaccines are offered at no cost, safety, reduction of risk of infection and effectiveness, these are the self-reported reasons for vaccine uptake among people living in prisons. Determinants of vaccine refusal, again, results from a statistical analysis. Distrust of staff, being female, being non-Hispanic, Black, or Asian, these are the determinants that are reported from different studies with different samples. Self-reported reason for vaccine refusal was also reported from various publications, like, for example, side effects, confidentiality, pain from needle, concerns about safety and effectiveness of vaccine. Vaccine is not recommended by physicians, and no need to vaccinate when you are healthy are self-reported reasons for vaccine refusals. Barriers towards implementation of vaccination program in prisons. Lack of audit of vaccine uptake due to high turnover of people living in prisons. Constrained resources and divergent organizational cultures and priorities between health department of the general population and the prison setting. Parental consent and unpredictable, often brief duration of juvenile detentions. And again, about juveniles, limited parental involvement to help access vaccination among juveniles. And criminal background check required by prison for volunteers or non-employees entering the jail. It's of a great importance here for us, because if we are talking about designing peer-led education, this will jeopardize our program. And again, interestingly, most of these publications, most of these studies are done during a crisis in prisons, either a pandemic, like for example, COVID, or an outbreak or epidemic or something like that. And we also found 4 publications, 4 studies offering vaccines to prisoners for research purposes. Interventions to increase vaccine uptake in prisons. Yeah, okay. Number of included publications containing this result, but this data was 16. And as you can see here, again, the US had highest number of publications with 10, followed by 3 in Europe and 3 other countries and regions. Nature of the interventions is most of them were implemented, 8 publications, 6 reported some recommendations, and 2 of them recorded both implemented and recommended. Types of interventions. Knowledge dissemination was basically the most common intervention. Prioritization of incarcerated people for vaccination. That was a study done in the US. They found that in the states in which people in prisons were prioritized to get vaccinated, vaccine uptake was much, much higher. Increased allocation of nursing personnel, targeting subpopulations, accelerated vaccine schedule, vaccination being opt-out compared to opt-in, recommendation of vaccine by physicians, motivational interviewing being mandatory. We don't support this idea, we're just reporting that. And service providers share the same racial background as a majority of youth and their family in attendance. Content of the educational courses, it was mostly, it's not surprising that it was mostly on safety, efficacy, and side effects of the vaccines and information on the target disease. And to wrap up, so I would say maybe the most important conclusion remark from this, from the data that we have extracted so far is lack of data and information. Many of you are very well aware of that. And the main focus of many publications is COVID-19. And again, as I said before, most of these publications and studies come from only one country, in specific the US. Majority of interventions are implemented during a crisis like outbreak, epidemic, or pandemic, and most implemented interventions are knowledge dissemination on target vaccines and the infection. So do I still have time for question and answers? Okay, good. So I have 3 questions for you. I would like to ask you later on these questions. So first of all, if you think we need to include other closed settings like forensic hospitals and refugee detention camps and so on, do you think is the methodology of a study acceptable and comprehensive enough? And do you think, and if you have any comments or suggestions for improvement, we will be more than happy to hear that. Thank you so much.
Thank you, Babak, for this overview. You will be one of the first discussants as you have questions to all of us. And our next speaker is Niall Walsh. Welcome. Niall comes from the Scientific Advisory Board of the Irish Penal Reform Trust. And
not scientific at all.
It is called so. And what I learned for the practical view yesterday evening, you are involved in interesting pay pathway house organizations. So yeah, maybe we can cover this in this discussion then also. And Niall will tell us what to consider when designing training and information materials for prison populations. The floor is yours.
Okay, so good morning, everyone. Can you hear me? My name is Niall Walsh, and when Lara and Angela asked me to give a presentation to a scientific group, I sort of squeamed a little bit because I'm not scientific. The Irish Penal Reform Trust is a board, like the charity that Emma was talking about in the UK around penal reform. So that's my sort of area, not scientific, really, but it's quite easy to give this presentation. Because as my role as the manager at Pathways Centre, and you'll see me I had put down some letters after my name because I was conscious there's a lot of doctors in the room, and again, that's not really why I'm here. The reason I'm here is I wasn't sure what to present, but I know what we've done in Ireland and actually worked, so I thought it was relatively easy to give the presentation to look at what we've done. In Pathways, just to briefly explain what it is we do, it's a post-release education centre. So someone starts their education in prison, they get released, they come to the city centre and engage with the education. We're fully qualified staff by teachers, and I do have lived experience of the criminal justice system. While it is lovely and I'm looking forward to the tour of San Vittore and Bolitante, I am also looking forward to the fact of leaving it at the evening, because we get to do that, and I'm conscious that the residents in here or the serving prisoners don't. The sort of clients we would deal with in Pathways are the same. This is international. It's the same issues that pop up in Dublin are the same, I'm sure, in Milan, and what you're dealing with here. You're dealing with mental health, addiction, homeless, high recidivism rates, multiple serving sentences, and it's trying to break that cycle. We have a mix of male and female, and you can read the slides. The idea is that people get daily release from the prison in the morning, they attend us and go back to prison at night, and as towards the end of their sentences then back into the community, because only but a very slim majority don't get back into the community. Majority of people come from our community and they go back into it. And it's important that for me and my role as the manager that we can do everything possible to get them back into society and back into paying tax, paying, putting kids in school, all the stuff that we do and we treat as normal, and they struggle with that. What to consider when designing the training? I'll just explain what we've done in Ireland. During the lockdowns, the same, you're talking there about stages of lockdown. In the beginning, it was fear-based, the whole prison's locked down. They'll close the courts, no school, gym. The actual, instead of bringing the prisoner to the court, the governor from the jail will go to the court and say, we're not bringing him to court. And murder trials, very serious cases, it just stops society down. 5 kilometres rule, you couldn't leave within 5 kilometres. I know you have particularly bad here. And the isolation, so if someone had to go to a court, they weren't seeing anyone, they were going from their cell back to court, and because they'd been outside in the society, they were back into isolation again, and this had severe effects on people's mental health, and not just for the prisoners, but for staff as well, for the healthcare workers, for the people, the Red Cross, the people, the chaplains in particular were just in there all the time. They used what was available, so the chaplains had access to all the areas, and they went around. The Irish Red Cross was instrumental in the rollout of the vaccine. The problem we had in Ireland wasn't particularly the people didn't want the vaccine, they couldn't get it. And the prison staff and the prisoners weren't as high categorized, or they weren't prioritized as they were in other countries because they were in that closed environment. And the previous speaker talking about the peer-led research, that is key. You need to give access. They need to take ownership of it, and it's people with convictions that can come back in. Ireland has progressed a lot in the last number of years that they do allow that, but that is key to getting successful people taking ownership of it. Train the trainer I put in there is thing. Surveys, they wanted to find out what was the fears on people, why they wouldn't take it. So they surveyed them and asked what would they change. Some of the stuff that came back, we're dealing with people with lower literacy rates, so it was put the graphics on it that people, it's interesting at the minute, the two prisons in Ireland with the lowest vaccine uptake is a remand prison, which has some migrants and foreign nationals, and Castlereagh prison, which would have a higher percentage of members of the travelling community. And you can see them now, they're sort of, well, I'll take members, I had a conversation last week, well, I'll take the vaccine, but don't tell me, I'm not going to tell my family on the outside, because there was such among their own community that they were won over by the literature, but they still didn't want their family to know that they were taken, which I thought was interesting. And these are just some of the points, and they will vary from country to country. What works in one country, they may be different. The information campaign is key. The surveys, I put the Netflix in cell and distraction packs because the teachers couldn't get in, so they were all these distraction packs, basically anything you could do in your cell, because there's people who were in the cell for 2 days at a time, and the teachers distributed that. Just discussion based, talk to people. There's no point in giving them chunks of information that's very hard to digest. You need to break it down. And the prison hierarchy and the social class. In Ireland, we have paramilitaries, and they sort of run that jail. I know the prison officers would disagree, but if you go in there, they run that jail. No one enters that landing unless they have access, and I don't know what the situation in various countries is. It's important to get buy-in from that and be aware of the hierarchy that I'm sure you have in Italy as well, that there's certain prisoners who are key to spreading that word around and to getting buy-in from the others. Senior prisoners, again, one thing that was very successful, and it was done despite some we got Professor Luke O'Neill in from Trinity College, and they got the peer-led or the Red Cross or the listeners, and they brought them from all around the country up into Mountjoy Prison and sat down. I have the video of it if someone's interested. He spent 2 hours, and they got the surveys and all the questions back and all the fears and myths and mistruths and the truth about the vaccine, and he came in, and that was massive in that their questions was answered. They recorded it and then put it on the prison education channel so they could actually see their question being answered by a professor. And the low literacy is an issue. Just another idea of two, maybe these are international even with the Red Cross, I'm not sure, but it's just to be aware of the literacy. Thankfully, we didn't have to go down. I was going to call this, and this is my last slide because I know we're running out of time. We were going to call it the carrot and stick approach, because, okay, here's what you can get. You can get your gyms back opened. You can get access to the school. You can have visits with your family. But the downside is if you don't, and we didn't have to go down this road, and I'm glad that it didn't go that way, but it was looking like that. Well, if you don't take the vaccine, the stick approach is you won't get access to the schools, the visits to families. But the uptake was so high that thankfully we didn't have to go down that road, which was a positive. I'll leave it there, and I look forward to the working groups later. Thanks.
Thank you very much for this very practical, very concrete overview. It doesn't work like this. Sorry. Yes, thank you very much for this very practical and concrete overview. And I think we have time for several questions. First, please, if you raise questions to each of the reference. Be so kind and identify yourself and to who you address the questions. So as for the moment, I see no raised hands.
No.
Then we said that Babak is going to give questions to us. So please, Babak, go ahead.
Thank you. And because I know Babak wants to talk, maybe I'll just start by you then. I have some questions about the data that was presented in terms of the studies that you have found. Sorry. Because for me it's not clear the different definitions that you have used. So you mentioned coverage and then you mentioned uptake. And it would be easier to understand maybe if you tell us what you understand by coverage and what you understand by uptake, because you also had a comment on the studies on effectiveness, so I think that will ease the understanding. And then I have also a question for Emma. I don't know if you want me to ask it now or... Okay, then Emma, I don't know where you're sitting. Hi. Emma, thanks. You mentioned you don't have the learning objectives yet defined, so maybe this question is stupid, but I'll try it anyway. So I don't know if you know, but I'm a pharmacist as background. And in Portugal, we have gone through a long period of trying to change the scope of practice of pharmacists. And there was a big battle with nurses because of the ability to vaccinate. And this, of course, is not specific to prisons, but it also applies to prisons. There's different realities in many of the countries. So one of the points that I wanted to understand was if you're talking about increasing literacy, if you're also considering the ability to vaccinate of the healthcare staff that's working in prisons, or if that is totally another topic.
It's my older brain, I can't retain information, so I have to answer immediately. Thank you, Philippa. I think that's a really good point. It's not actually something that's within the scope of this project, but surely actually it's going to emerge somewhere from our scoping reviews and something like that. But actually looking at the who's going to do it isn't actually going to be specifically part of this, our work, certainly in work package 6. But it's also really interesting about who you get your recommendation from, and it might be that who do you get your vaccine from too is really important. But yeah, and really good point. Thank you.
And thank you. Well, the point is coverage. It refers to whether a person is already, has already received the vaccine before prison or not. It can be partly outside the prison. And uptake means if they have received the vaccine inside prisons. And I found one publication with, suggesting some specific definitions for that, and some actually different definitions for that. But the point is, after reviewing these 30 publications, some of them were giving the impression that they are mixing up uptake and coverage. And this is something that we need to talk to, I need to talk to the whole team about that. One other thing that I need to mention is these 30 publications, they need to be assessed in terms of quality. And this has not been done. This is something that, I mean, some of them may be removed, and the whole team will decide about that. And about the effectiveness, again, as many of you know, in public health, we differentiate between efficacy, efficiency, and effectiveness. And this is something that I was clearly seeing that, again, some papers, some researchers, authors, they were mixing up all these things. And first I wanted to mention efficacy of vaccine or intervention over there, but it was not reported. So I changed that to effectiveness, and I reported that kind of partly qualitative information that the authors reported. The point is, to evaluate efficacy, I mean, most of you may know, we need randomized controlled trials. We need two groups of people who are randomly allocated. One is receiving the intervention and the other one is not. Then we compare the results of these two, and we come to the conclusion that is at the end the intervention effective or not. But we couldn't find any information about such. I mean, we couldn't find such study designs at least in these 30 publications that we have evaluated so far.
There is a question by Dr. Linda Montanario, MCDDA. Linda, you could be able to talk if you want to make your question yourself.
Hello, everyone.
Oh,
can you hear?
Yeah, we can hear you. Thank you.
So I'm very sorry not to be able to be here with all of you, especially in San Vittore in Milano. I have a question for Babak. Just maybe he say, and I miss it. I wanted to ask if in the scoping review it was included the grey literature and also which languages, because I see it was all US. So I was wondering if there was some, non-English language that was missed.
Yeah, thank you so much. Yes, as I mentioned in my presentation, we also searched grey literature. I think, if I'm not wrong, 12 databases. And what was the next? Oh, the languages. Well, our search was actually in English language, but we found publications on very many different languages, like, for example, Portuguese, Russian, German, and Spanish. Some languages were included, and we didn't exclude the identified publications because of the languages other than English. I used DeepL to translate the summaries and also in a couple of cases the full texts.
Okay, so also the grey literature, the non peer review articles were included.
Yes, exactly.
Okay.
Yeah.
Thanks.
Sure.
Yes, please.
What I presented today was results of 30 peer-reviewed publications, but afterwards we will also start with the grey literature, and at the end all these results will be combined and presented together. Right.
Many thanks.
Any other? Yes, please. Yeah.
Okay, I have one question for Emma and one for Babak, comments more than questions. So to Emma is related to, first of all, the vaccine literacy increase training that you're thinking to develop. Do you, the evaluation, you just mentioned the evaluation, are you going to do a sort of baseline of the vaccination literacy and then the evaluation of the impact of the training course you will do? Because I didn't pick it up. First. Second, I understood that the beneficiary of the course are both health staff and custodial staff in prisons. Are you probably they have a different background, so are going to be two different courses or two different track of courses because their vaccination literacy obviously will be different. And to Babak is more a comments. At the end, you asked if you were requesting, if we were suggesting you to include also migrants, refugee camps in the literature and so on. To me, that since I'm working with migrants, it's quite complicated for several things. One, because it's not just refugee camps. You need to focus on hotspot and on the Center for Detention and Rejection of the things. There are very little information about, and is managed by the Ministry of Interior usually, and not Ministry of Justice. And there is very, very little information about. We are doing something with the Migrant Lancet Commission on this, and it's very difficult to have information. So cannot be only refugee camp, and probably you will not find anything. This is my impression. Okay.
Thank you. More really pertinent questions. Thank you. I'll probably take your second question first, which is probably easier to answer and more straightforward. You asked about whether we were going to do separate courses for the staff, for the health versus the custodial. That's the answer. The short answer is we don't know yet, but it's very much one of the things we wanted to talk with people about today. It's something we want to talk to our reference group about. I think we need to understand first exactly what those learning outcomes need to be, what we need to cover, because you think obviously the health staff must have a higher understanding, level of initial understanding than the custodial staff. But I think we need to tease that out a little more. I mean, my ideas at the moment, and I want them to be informed by everybody, is that maybe we have a sort of introductory course that perhaps the custodial staff can do to almost bring them up to the same level as the healthcare staff, and then you have a main course. So it might be some model like that, but it's something I really want to talk to people and canvass thoughts on today, and obviously formally our reference group will be talking about that. The other thing was evaluation. I think we're going to be evaluating in many different ways. We're going to the Future Learn, which is a learning platform for that we'll be using for the staff. We'll be doing some process stuff about how many participate, all those sorts of things. We'll also be doing sort of the fairly basic educational questions about did it meet your learning objectives, things like that. So there's that sort of basic stuff. Perhaps the more important stuff is this shift of attitudes and understanding. And I think, Laura, I don't know, in terms of work package 5 comes in here too, and the broader evaluation. So I think it's going to be quite a complex evaluation with many different facets, and they're sort of aspects that we in our work package we'll be leading on, but other aspects that other people are going to lead on, but we'll be working together to ensure it all nicely meets up and we can learn from it.
Thank you very much. Sorry, yeah.
Thank you for your point. Just very briefly, among these 30 publications, I found only one reporting data on one intervention in a detention center in Israel, and they were focusing on providing this intervention, emphasizing the language of the service providers. Because apparently most of the target population, they were Arab speaking, and they also targeted, they also asked the Arab service providers to do that. And I found this interesting, and I thought maybe we should include that. But thank you so much for the point. It's going to be, again, a shared decision between the team members, and if the all the team decides to exclude this, we will do that.
Yes. There is one more question.
Thank you very much. Very interesting 3 presentations to kickstart our meeting. Thank you very much. Thanks to Emma, Babak, and Niall, of course. I have one question and one comment. The first one is to Babak. Did I get it right from your slides that the range for the uptake, it's ranging from 0 to 95.5%? And this is quite a wide range. And I'm not sure, Laura, if the project's perspectives will allow to go deeper and dig deeper for this, because this is very, very interesting data, I would say. And we need to analyze it and what about this 0%? What happened with the modalities of implementation? What did we do wrong? And also to do the same for the successful or higher rates as well. So I think 0% uptake of a vaccine in prison or in closed setting, that's worrisome, and we need to go for analyzing this. And I would like to invite the scientific advisory group, I'm one of them, to analyze it and also to come up with measures to mitigate this situation in the future. This is the value of this project, and thanks for this. My second point is about the effectiveness of the vaccine. I think what has been raised before, you also said that the effectiveness of the vaccine will need a randomized clinical trial. I fully agree with you. I'm not sure if we can do or measure the effectiveness of a vaccine. Vaccine we are using in prison has been proven, and if proven to be effective, and to measure the effectiveness for this might be a bit risky to do it in prisons in such a small scale, and maybe we can rename it for measuring the impact, the outcome of a vaccine program or something like this. But maybe I'm sharing my thoughts with you to reconsider using the word effectiveness in this part, if we all agree on that. Thank you very much.
I think this was a very important remark. Thank you for that, Ehab. We ran out of time and we apologize. We got the signal we should close the session in order to leave room for the next one. Thank you.
Well, should I answer or at least very briefly, should I answer the question very briefly or not anymore?
Yes.
Okay.
You're right, it was one question. I thought it was just a comment.
Sure.
But you are right.
Sure.
Thank you.
But the point is that's 0%. It's a little bit confusing, but it's interesting for you to know that. Again, back to the definition of coverage and uptake. It was a study in which all staff members were already vaccinated outside prison, and the coverage was 100%. Therefore, the uptake was 0%, exactly. So this is a thing that I really didn't have time to go through the details, but yeah. But I think the next least number percentage of uptake was 24%, if I'm not wrong. yeah, this is, but you're totally right. It needs to be evaluated in detail. Yeah, thank you.
Hi, Heino. Now let's have our coffee break. You may leave your personal objects inside because the room will be closed during the break. We meet here at 11:45 punctual. I recommend. If you need any mask, we have there.
We can speak on the other side. loro, però a volte I'm sorry. I have to go. Yeah. Okay. Nicola, hai tu la chiave? Sì, ce l'ho io la chiave. Ok.
Ma tanto ci sono loro, non è che li posso chiudere dentro.
Ah, ok, no, perché mi hanno chiesto, ma le cose le lasciamo qui.
No, li vediamo.
Ho detto, state tranquilli, siamo in prigione.
Devo dire io che li vediamo per pagarci la cena.
Esatto.
Io però mi lascio fare. Mi fate insieme.
So you got all the technical into it.
No, actually, I am the doctor, right? Just kidding.
Is it because there's no
Yeah, it's a big challenge.
yeah, sure.
We are doing the best, all our
Of
best.
course, I mean, this happens all the time.
Doctor.
It's not.
Se in difficoltà, al massimo questo lo prendo in mano, però mi sa che...
No, così prova, solo che io devo leggere, quindi che io leggerò. Metto qua sopra, va bene, dai. Ok. Sì.
Sì, rifacciamo sempre la così. C'è un po' di senso.
Provo sentire sento sei in direzione. Yes, exactly. Yeah. Okay, yes. Yeah, sure. It's difficult to keep track of people, right? Even in a prison, they disappear.
Sorry.
Hi. Sorry, before starting, we have printed some materials for your folders. In paper, it's there. So if you want to take it, it is maybe useful for our next sessions. Thank you.
I think it's
already working. It's great. Yeah. Nice to meet you.
nice to meet you.
Hi, how are you? I'm fine.
plan, timeline.
Good late morning and welcome back from the coffee break. I thought myself that it was very refreshing both to have a coffee and be out in the nice prison yard. So thank you for that break. The last session we had before the break was about vaccine literacy and tailored interventions. And as far as I understand, both for people in prison and prison staff, sorry. The next session will be more about access to vaccination in prison settings. What, so to speak, needs to be in place before vaccination can actually happen, regardless, in a way, of people's perceptions of vaccination. You may know our commissioner for health, Stella Kyriakides. She normally says that it's not vaccines that work, but vaccination does. So, of course, there needs to be vaccine acceptance. We need to work on people's perceptions of vaccination. On the other hand, there also need to be simply vaccination services in place so that this vaccination act can actually happen. And these vaccination services also in prison need to be accessible, they need to be efficient, they need to be appealing. And as far as I understand, this is what we will address now in this session. So I'm looking very much forward. But I hope that Mr. Giuliano will maybe also say a couple of words as an introduction. Thank you.
Yeah, no, thank you. I think if the previous section was more kind of background information, now we are entering really in the business, colleagues, and I think it's very important discussion because I mean here we are looking a bit at the landscape, but also I mean more in practice, you know, what type of vaccination we aim to, and what are also the new vaccine and the new typology of existing vaccine, also to simplify and to improve, you know, both the acceptance but also the capacity to deliver a complete vaccination package. We will have also a session during this section. We will have also some speakers from that will talk about their exposure to the vaccination activity. Some of our staff from San Vittore Prison will give us a speech, you know, their experience to deal with vaccination in emergency, as we did the COVID vaccination, but also overall, you know, the impact on their work and the impact on the health of the people that get vaccination. So,
yes, I guess we should then introduce the first speaker, and that would be, and I apologize for any bad pronunciation of names, that would be Filipa Alves da Costa. And I guess it's for me and Mr. Giuliano to move a bit away so that the speakers can sit in the middle.
No, I think they will stay there.
Okay.
Okay. Thank you. Pronunciation was perfect. Yes, my name is Filipe Alves da Costa. It sounds exactly the same. So thank you for the opportunity to come here and be part of this wonderful meeting and get to meet San Vittore Prison, which is obviously the most attractive part of the event. So I hope I do not make you sad after this introduction that this was going to be the real part. So what I come here to present is just some preliminary data from WHO Health in Prisons program. So just to give you a bit of background, so the Health in Prisons program is something that was created in the WHO European region in 1994. And it's the only region within WHO that has this program devoted to prisons. In 2016, because there was a general feeling that was already discussed today that there's very little data and about what happens really inside prisons, we developed this Health in Prisons European database, which is referred to as HIPET. And this database collects, gathers information collected through a survey that is sent to all 53 member states of the WHO European region periodically, where we try to characterize the prison health system and the health status of people living in prisons. So the first report that was published using this data was in 2019. And then throughout 2020, we developed the second version of the survey, improving some parts of it. And in 2021, we have published this WHO Health in Prisons framework, which is aimed at improving the quality of data collection, trying to make it more structured. So I realize it is a bit difficult for you to see the slide, but I'll take you through it because this is essential really to understand what I'm going to present next. So this describes the way that we can characterize health prison systems. So we have a first section, which is the inputs. So it's called health system, and it is really what you put into the system. So the organization, the financing, the health system vision and strategy, and the health information part. Then we have the second block, which is what you get out of the system when all these things are working. So you have preventive services being offered to the prison population, and within those you have subsections, which are disease prevention, health protection, and health promotion. Then you have medical care, which of course includes primary care, but also hospital care and specialized care. And then you also have continuity of care. And I also thank my chair, Robert Giuliani, who already made this this focus on rehabilitation, which of course in prison is an essential component of medical care. So we also have that in that second block. And then we have another part which is extremely important, which is the performance, how we know that the services that are being delivered are really accessible to the population, are available, are acceptable, and have high quality. And then we have the third block, which is the health outcomes. So when you have the inputs and outputs, how they translate into the health of the prison population. Then we have mediating factors, so the influencing factors which will change this relation, and these are the prison environment and the health behaviors. And then there are the cross-cutting principles 1 and 2, which mostly refer to international standards for human rights and also to reducing health inequalities. So when we collected information, we try to organize all the presentation of information according to these building blocks. I will not have time, obviously, to cover all of them, so I will just focus a few highlights. So we have the first results now being available. We had only 36 member states providing valid answers. That is, of course, good, but we have 53, so it's not great. And this covers 613,000 people living in prison. The mean incarceration rate was 107.7 per 100,000 inhabitants, and the occupancy rate 86.7. On average, there were nearly 50 prison establishments per country, but bear in mind that all the next results have quite wide confidence intervals, so of course there's lots of variability here. The mean time of incarceration was nearly 2 years, but again with wide confidence intervals. I will just highlight in this slide that, so this just shows you the general demographics of the prison population, and so it's not that interesting, but what I find most interesting in this graph is that in the previous report we had many member states who were not able to disaggregate information, and in here we also see the same. So the biggest number is 36, you see it on the left hand side, and only for gender, all member states were able to disaggregate. And then if we go down, we have some parts of information which are really difficult for people to provide, like minorities, for example. And then we have some in the middle, like the proportion of people that have disabilities living in prison. But I think in general it is improving. So in terms of organization of healthcare systems, we focused mainly on the difference that exists between the prison and the community, and we see that there was a higher proportion of national government being responsible for healthcare in prisons when compared to the general population. This is what's being shown in this graph. Then we asked about if people were collecting information on and documenting consent from people in prison when any kind of procedure was being delivered to them. And we were glad to see that only roughly 5% are not doing this. The difference being between collecting and documenting. In terms of health information, this is interesting because it just shows you that when we talk, so the first graph, we look at the health information system in general, and we asked if they have a system in place that's interoperable with the community. And what we can see here is that in more than 50% of member states, the answer is no. But when we ask the same for COVID-19, the response changes dramatically. So if you look at the lower graph, you see that in terms of immunization information, this was available for nearly 95% of member states. So again, this was already discussed in the initial session, but it's just showing you that when there's will and need, there is power, so things can improve. In terms of quality of care, we see some room for improvement here. So the first one is just talking about the availability of essential medicines, where of course vaccines are included. And only, I would say this is too high. In a bit more than 10% of member states, there are no regular assessments being performed. So in a way, this is worrying. But I would say even worse is the standardized process for reporting adverse drug events in prisons seems to be something that's really not being done yet. Now I get to the more perhaps interesting for RISE-Vac. which is so we have this domain which can be seen. I forgot to mention this. So we can have domains that are part of two of my initial framework. So for example, vaccines, we can cover that under preventive services, of course, but we can also cover that under performance because it also refers to accessibility. So here I put it as accessibility, but it doesn't matter because the answers are the same. So we can see that the options are if we asked for a certain vaccine, if it's available in all prisons in the country, majority, minority, or none. And the biggest bar is again COVID-19, but I would like to stress the two main points, the two worst points, which were already referred by Martin also in her introduction, which refers to availability of HPV and hepatitis B. It's not the worst, but it's nearly there. And these two, as you know, are highly recommended and are for cancer preventable morbidity. So there's room for improvement there. We also asked about accessibility to HIV pre-exposure and post-exposure prophylaxis. Actually, here I was quite surprised because I expected much worse. And in most member states, the answer is yes, it is available in all prisons, although better for post than for pre-prophylaxis, of course. I think I will finalize with this one, which is also about screening. And I just asked for a last change because of this slide, because of the introduction. So I had initially just focused on infectious diseases. And the main aim was to show you that on the left-hand side, you see HIV, HBV, HCV, and sexually transmitted infections. And in most member states, all of these screenings are available. The main difference is if they are available as opt-out or as opt-in basis, or in some cases, risk-based screening. So the modalities change in terms of proportion, depending on the type of infection that we're looking at. But I also added the graph on the right, which again, of course, it is infectious, but it's mainly because in the survey we organize it under a different section, which is non-communicable diseases, to add the cervical cancer. So in here, the answers were that roughly 67% of member states were regularly screening for cervical cancer in prisons. And the only cancer that is lower is colorectal cancer. So I could show you lots of additional points, but I don't think I have time to do this. So I would just go directly to the points for discussion, which is what data we are not collecting. And I think this is where synergies are most useful. So, of course, I'll start with our internal comparisons. So in our previous publication in 2019, we said that there were 31% of member states which were not providing a full vaccination course for hepatitis B. In the current wave, it seems that things have improved a little. It's still not available in 6 member states, which represents 17%. But I think we are looking at slightly different things and coming to Babak and the definitions. So what we're asking is if it's available in prison. We don't know if the fact of being available makes it
being uptaken by people. So we don't have the vaccination coverage or uptake, how you want to define it. That's something we don't know. And I think even if we would have added that to the survey, we would have not obtained valid answers. So of course it would be extremely important to get the synergy from RISE-Vac. Thank you.
Thank you very much. So I think we will take all the questions for the end. So next presentation is Nicola Cocco from our group and Sara Mazzilli from University of Pisa, that will talk about the translating emergency into routine practice from COVID-19 vaccination to expanded routination vaccine offer in prison. Yeah, as the title said, I think COVID gave us a good opportunity outside, but also inside prison, to boost the vaccination. Now the point is more, what we can get out of this experience, and we can translate in other vaccination practices. Dottoressa Mazzilli, the floor is yours.
Thank you. How can I change slide? Because now now I can. Okay. Good morning to everybody. In this presentation, Nicola and myself, we are going to show you which are the in the vaccination practice already in place in the prison partner of RISE-Vac. Then we will see also what they have done during the COVID-19 pandemic to implement the COVID-19 vaccination. And then Nicola will also show you which we would like to achieve in the framework of RISE-Vac in terms of increase the offering of vaccination in this prison facility. Well, we in work package 5, with the help of Davide, we have collect data on the immunization activity in the partner country, and this is the first thing I will show you. And then we also did a survey to the prison partner to ask them the challenges, and then how they overcome these challenges in implementing the COVID-19 vaccination. And then Nicola will present 2 vaccination schedules, a minimum and a gold standard, to be implemented, that we will be implemented in the framework of RISE-Vac. And then he will also present the model of care with which San Vittore will increase the offer of vaccination to people living in prison and prison staff. So for the first survey, where we were asking to the prison facility the standard vaccination routine vaccination, we have this prison, 3 prisons from Moldova, 4 from Italy, 1 for France, 2 from Germany, and 1 for Cyprus. We were not able to collect the data from UK, but we will add them very soon. You can see that we have a very different type of prison. We are pre-trial, short and long-term prison, juvenile, and also in terms of inmates composition, we have male and female prison, male only and female only prison. First, we ask about the prison staff. Which kind of assessment was done for the vaccination at the time of the employment? And you can see that for all the country were assessing hepatitis B and COVID-19, but there are some vaccinations that can be relevant to the staff that were not assessed in some of the country. There is the situation is not homogeneous, and there are countries that
assessing for different type of vaccine. The human papilloma virus is not assessed for this population. And then we ask also if there was like a regular basis, a periodic assessment of the vaccination status of the prison staff. And for 4 of the prison, there was, both for medical and non-medical staff members. For other 4, there was assessment only for medical staff. In 2 prisons, just for COVID, this regular assessment. And in 1 prison, there was not then an assessment after employment. For what concerns people living in prison, these are the vaccination offered to this population. You can see that the situation is heterogeneous. The only vaccine that is available in all the prison is COVID-19. That's why, in order to one task of the work package 7 is was to collect model of care of vaccination, to design then model of care that can be useful to implement the vaccine, to increase the offer in this project. And we decided to focus on the COVID-19 implementation because it was done in all the partner country, and actually it can be an example, even represent a gold standard in terms of vaccination in prison. You can see that in all the country involved in our project, there was the specific recommendation to provide vaccination in prison in the vaccination plan. Most of the countries start to vaccinate inmates quite early, in February or March. The only exception is the UK, that they start in December. For all the prison, the vaccination delivery was available inside the prison. And in all the prison, there was the introduction of educational meeting and informational material, both for prison staff and people living in prison. That this is it's a good example of vaccine implementation. The prison also reports some challenges and limits in the implementation of this vaccine. These are the most, the one that were mostly reported. Shortage of health staff, challenging of cold supply chain, lack of referral system to get the vaccine for when the inmates was released, paper-based health registry not integrated with the one used at the community level, a high level of vaccine hesitancy. But in this emergency, the prison, they sort out a way to overcome these challenges. For instance, for the shortage of health staff, San Vittore is an example in this. They did task shift, or is not, I don't know, I mean, the nursing was more, and also the prison staff were more involved in the organizational part of the vaccination. We didn't provide the vaccination itself, but still it's an organizational improvement somehow, and also additional staff was hired. And it's important that if we want to expand the vaccination, the provision of also other vaccination, we have to have a clear allocation of responsibility if we want to keep involving all the prison staff available in the facility. The challenges of cold supply chain, there were not enough refrigerator, and this was a main problem, but they organized vaccination days with collective vaccine administration. And I think also for other vaccination, this can be a good idea to implement, also because it may, the organization of the work of the health personnel can be easily done if the vaccination is offered 1 day per week or 2 weeks, once or every 2 weeks. And also it can help in reducing the vaccination refusal because for the imitating peer behavior, if the other inmates are getting the vaccine, the more reluctant inmates may think that they also can do that, and the refusal level can be reduced. The lack of referral system. The prison that we interview were given the list of structure where they can, when the inmates, once they were released, can go to get the second dose, the booster doses. But in San Vittore, they did a very smart thing, I think. They planned already the appointment for people that were released, and then they get the vaccine to these people in a intensive structure outside the prison, And of course, to translate this practice into routine, it may not be feasible to have a intensive structure for all the vaccination, but to facilitate the procedure to plan the appointment in the community vaccination center when they are released, it's crucial to have an immunization information system that communicates to the one in the community. And actually, we saw, as Filippa was mentioned, that that's possible for COVID-19 vaccination. Most of the prison interview had the same immunization information system of the community, but that was not in place before COVID. For other kind of vaccination, the systems are not connected, they not communicate to each other. And we will advocate in the framework of RISE-Vac for implementing a better immunization information system. Lastly, the high level of vaccination hesitancy. We have seen that all the prison implemented the educational meeting and share with inmates and prison staff informational material, and these have to be something that is periodical, that is done in a regular basis, and it's what we hope to promote in the framework of RISE-Vac. This is exactly what we want to achieve in the end with all Emma is leading. In the end, we ask I don't know if it's uptake or cover, now I'm confused, but we ask the proportion of individuals who complete the COVID-19 vaccination before the release. And in Moldova, France and UK, they report among 50 and 75%. In Italy, Cyprus and Germany, even higher, among 75 and 90%. One crucial point that we have noticed, giving this questionnaire to the prison facility, that the proportion of unvaccinated individuals among newcomers, people that arrive in prison, was quite high in Moldova, France, UK, among 50 and 60%. And Italy, Cyprus, and Germany, among 10 and 20%. So, again, we want to remind that prison can be a point of access to healthcare. We wish integrated prison community healthcare, but healthcare maybe it's enough for now, and then we will hope to improve also this integrated part. And that this data show that universal immunization campaign, when there is the commitment to implement them, are feasible, acceptable, and effective, even in place of detention. And now I give the floor to Nicola to continue.
Okay, thank you again for being here in San Vittore, and thank you, Sara, for this picture of from which we have started to try to talk about implementation, this very difficult word. Okay, so Sara was talking about the coverage of COVID-19 vaccination. I have just put some graph because I think it's very important to give a look to what happened in prison about COVID-19 vaccination. In most European countries, the vaccination in prison has been done, and it has been also better than outside the prison. I think this is not so obvious. I think this is relevant. And I've put the specific situation also of our countries to see how the first dose, the second dose, they had higher rates in prison rather than outside. But it's much easier to see with these. These are our data from our Ministry of Justice. You can see that after the first period when the vaccination inside prison was a bit slow, at a certain point, vaccination in prison have they went over the one outside the prison. This is relevant. What can we say about the hesitancy, the acceptance that we just mentioned before? Okay, this is a study I found interesting, even if it is from US, when the prison setting completely different, of course. But they have built a score of trust with the personal health, with health staff inside the prison, and they have seen that the higher this score of trust, the higher the acceptance. You can say, okay, thank you, this is quite obvious. It's not obvious. It's not obvious because this means that behind the hesitancy, behind the acceptance rate, there is a big work to build the trust with patients, even these patients are people in prison. Okay, so this was just to stick with what Sarah was telling before, but now we try to build a schedule. How we build a vaccination schedule that could be ideal? I've taken some data to say, okay, what is working now? One example that is very important to me is the HPV vaccination. This is an example from Denmark, so I think it's quite reliable, where the acceptance of the vaccination, of the HPV vaccination in prison is always very high, both if they were presenting a standard schedule or if they were presenting a very rapid schedule of HPV. For those of you who doesn't know, is a schedule where the doses are given at 1st, 7th, and 21st day. So very quick schedule. You can see the third dose of the HPV vaccination was done in 63% of people who underwent the very rapid schedule, and only the 20% of people that underwent the standard. We have the same problem here in our prison where we work. The third dose of HPV is very challenging. So maybe we should think about these things. We should think, okay, maybe we can use a rapid schedule. Is there literature about the efficacy, the effectiveness, all you want to say about this rapid schedule? I have seen that from the main studies, they have also demonstrated that the shorter period for HPV, the NGRX-B, that is the most used, is 4 weeks. But there is a problem that they don't tell. Also the Denmark friends, the Danish friends that made a study before, you need to do a booster after 1 year, if you want to be sure that it's covering. Okay, the Danish of the study before, they thought, okay, but we checked after the 3 doses and the immunization response was still high. Okay, but the indication for the gold standard is still with booster after 1 year, and 1 year is a lot talking about prison. So here in San Vittore, with Roberto, with Ruggero, we are trying to say, okay, maybe there is another schedule for hepatitis B. There is this Eplisav that is a 2-dose schedule, no? At 1 month of distance, very quick. 1 month is acceptable in a prison. You can see that the endpoint for the immunitary response is good. Is good both for young people and for the elder, because we have to vaccinate for hepatitis B also old people, because the medium age in prison is increasing. So I am proposing HPV vaccination also to people that are older than 55 years, for example. So this is just to make you some example. Maybe we can accelerate some schedule if this is one of the challenge. For example, another way to accelerate. Let's think about how is the world working about vaccination. Maybe to people that are less than 30 and 25 years, for some vaccination, we could give for assured that they have done a cycle of vaccination. This is the coverage of hepatitis B in the world. Okay, maybe if we know that people are coming from places when we can have a certain story of vaccination, or we can say, okay, from the official schedule, they should have been vaccinated for hepatitis B. Maybe we could just give the booster. This is just a suggestion. I'm not suggesting this could be the standard. We are suggesting it. Maybe we should just give the booster for hepatitis B to young people coming from places where the vaccination is widespread. And this is the same for measles. For measles, we are not giving here this booster yet, but I think that the booster for measles should be enough. If we know that in other countries it is quite widespread, and also from the medical history of the patients, we can say, okay, probably these patients have underwent the vaccination for measles. Okay, this was just to say, okay, so let's start to build a standard. We will suggest two standards that we think would be a good point of discussion for our member countries. So the first minimum standard is the one with hepatitis B, considering all the discussion I was making before, so rapid schedule, booster, etc. The booster of tetanus, diphtheritis pertussis, of course, the pneumococcal vaccine for all the specific conditions for elder people, the measles, considering the booster, the flu, and of course the COVID vaccine. But as Filippa showed before very well, it's like this is the last of our problem now. The COVID vaccination is quite, after a lot of struggling, is there. So we consider this to be really the minimum core standard that all countries participating in this project should try to assure. And then there is another standard that is the gold one. And this is the one that, for example, we are the first of the class, of course, we are trying to reach as a gold standard, is given with the core standard, of course, and then to add the meningococcal vaccination for specific condition, the Haemophilus B vaccination for specific condition. I'm not going inside the specific condition, of course. Papillomavirus, we were talking a lot before, it's important, and not only for women. It's fundamental today for HIV, for men who have sex with men. There are a lot of studies now that are published about the importance of HPV. And then there is the varicella virus. Also, the WHO now is stressing a lot about the varicella vaccination. We can do this. And in fact, I will tell you later that a focus of our project will be in the Milano prison about the varicella vaccination. And finally, the hepatitis A, that is a bit neglected, but hepatitis A is important both for the environmental transmission that for the sexual one. So this is the gold standard that we suggest. And what about the prison staff? Well, we know that the prison staff has to be vaccinated, of course. We know that there are two routes. The main routes, I think, is like, for example, in Italy, people working in prison, they have to undergo vaccination through the work medicine, the job medicine, no? For example, and this is very important to check if everybody is doing this. But for other places where this system is not is not settled or is not working well, maybe we could think also to provide vaccination for prison staff. For sure, we have to have in mind that the people working in prison should have the same minimum vaccination schedule of the one we suggest for people living in prison. Otherwise, we are really creating a double standard, and this is not possible. And of course, we have to think that vaccination are also measures of professional medicine. So we can consider that some vaccination should be delivered for specific environmental or professional risk. Of course, hepatitis B, we know for if people are getting armed with a needle, for example, but for example, flu vaccination or measles vaccination in the case of epidemics inside the prison. So just to summarize, we have to think about tailoring the schedules, and we have to think about the means to accelerate these schedules. We have to think about specific people, a specific population, and then talking about migrants and also young and elders and all the fragile people are at the center of the RISE-Vac project, and we have to tailor our vaccination schedule also on them. One aspect that now I will go further with our proposal for San Vittore is to create a connection with the outside territory. And the point is that prison can become a sort of health center. I know that before one of the authorities told that prison can be harmful. Okay, we want to also to demonstrate that if it's working well, prison can create health. For example, building a vaccination clinic. Okay, this is inside San Vittore, which is the mission of this project. Of course, is to increase the diffusion of vaccination inside the prison, but also with the specific objects that are to reach the fragile and to increase and improve the connection with local health services. So what are we doing? We start choosing that, okay, we have to reach the gold standard because we are already on the core standard. We have to work with the pharmacy and all the other, with all the other people working for vaccination to reach the gold standard inside San Vittore with a focus for varicella vaccination in all the Milano prison. Why? Because varicella vaccination is very well indicated now for old people. And in a prison like Opera or Bollate, where are living people older, this become very, very, very important. Which will be the staff? There will be the infectious disease doctor, the nurse, and an health worker with the anthropological background that you will hear later. We will work once a week about this vaccination, ruling on this vaccination clinic. Then there will be the involvement, of course, of pharmacy and the water and the warehouse. We cannot work alone. It's very complicated working for vaccination because you have to create a connection between a lot of people, and it's not always easy to discuss. We will try. We have discussed it a bit with Davide Petri, with the idea to start using our tool of collection of data, data collection tool for RISE-Vac. We will try to use it as a pilot, for example. We also suggested the name of the tool to be RISE. I don't know if you will agree, but we think it's a good name for a tool to collect data for vaccination. So the idea is to make this prison a vaccination hub. It's something that for COVID-19 just happened 1 year ago. We want to make it possible for all the vaccination. And I will close this with this sentence that you can say, okay, Nicola, maybe you are very young, but this sentence is very easy. Vaccination will always be very useful. Okay, I will greet you with the fact that this sentence was said by the doctor of Milano, working in Pavia in 1816, because he wrote this paper about the discovery of vaccine politically considered. So already at the beginning of the vaccination story, it was very clear the role, the social role of vaccination. And I thank you. But before I will leave the floor to Marianna Polidoro, that is our health worker with the anthropological background that worked inside San Vittore during the vaccination, COVID-19 vaccination campaign. Thank you.
So, okay. Good morning, everybody, again. So, my work in San Vittore Prison House begins on May 2020, when the pandemic has already made significant changes, such as the suspension of all resocializing activities, training, and face-to-face visits with family members, lawyers, etc. In the first months, my job mainly concerned the sensitization of the prison population about hygienic rules in inmates and preventing the spread of the virus. In this first phase, the collaboration with the central warehouse of the Institute was essential for the supply of products for personal hygiene and for cleaning prison cells and personal spaces. Many people, especially newcomers, were skeptical to my invitation to personal and environmental care because, according to them, the conditions of prison overcrowding clashed with the current legislation on social distancing outside the prison due to the reduced spaces of coexistence in prison, you know. The COVID-19 vaccine arrived in prison over a few months, but quite quickly compared the public discussion about priorities and special population. During the first vaccination campaign in this institute in the first half of 2021, many inmates responded well to the possibility of being vaccinated in prison. We have guaranteed many vaccination sessions in all the sections of this institute. Trying to settle our health intervention with the prison staff, with the available spaces, and with those inmates who gave a first verbal consent and then refused the day of the vaccination session. Of course, this made slowdowns and wasting time, but we all know how much the vaccination campaign has encountered problems even outside the prison. So you can imagine in complex contexts like this. After that period, it was essential for us to be able to guarantee the second dose of COVID-19 vaccine to those who, once released, could have encountered many challenges in booking an appointment outside the prison. So we thought of implementing a space just outside the prison, a civil protection tent located in the back of this institute, where we welcomed many former inmates who returned to complete the primary COVID-19 vaccination cycle. We also guaranteed the release of COVID-19 certificates, so-called here Green Pass, and sent them by email because we were not equipped to materially produce the certificate in the tent. Again, we had adapted to the context. The second half of 2021 has been characterized by frenetic attention to the issue of the Green Pass, compulsory to obtaining a job in prison, and for visit with family members, lawyers, and other professionals. During my visits to the prison section, I saw that new doubts clearly emerged related to the uncertainty of a vaccine that needed more than one dose within a short time. Many asked for a meeting with an infectious disease doctor other than the section doctor. Others asked for a serological test. Many inmates refused the vaccine due to substantial tendency to interpret the pandemic as a part of conspiracy, but also from the belief that they have a good physical condition which did not need to undergo the vaccination. Or, as many declared, I'm sorry. Yes. I'm sorry. Yes, for fear. The point very important, for fear of a vaccine studied in a short time, or for distrust of health in prisons. These have been the main reason for hesitancy or of refusal, and we will work as a team in studying the deeper reason of hesitancy and how to strengthen the trust with us health workers. Anyway, as clearly showed, COVID-19 vaccination rate in Italy and particularly in this institute has been good, considering all the challenges faced by people living in prison and by prison staff. Today, adhesion to COVID-19 vaccination is quite constant for a good number of patients, despite rumors of the hypothetical end of the pandemic. For about a month, we have had more appropriate spaces for the continuation of the vaccination campaign against COVID-19. All these aspects that I have shared with you and the other doctors shared with you confirm in the field that vaccination campaign in prison can be effective, and we will be able to use the novelties brought for the COVID vaccination campaign to implement a real vaccination hub here in San Vittore. Thanks for your attention, and I'm finished. Thank you.
I don't think it's coming. Sorry, it was cancelled the last speaker.
Oh, sorry. We also asked a prison nurse to join us to describe the vaccination campaign inside prison. Unluckily, he cannot come for a family reason, but it's interesting that they participated also in the preparation of this session.
Thank you to all the speakers. So now we have some space, some time for a question, please.
Consideration and question. First of all, I want to congratulate you very much for your work and for the impressive presentation you gave us today. Some consideration. You wondered about the height coverage reached inside prison, about the vaccination for COVID. This is not so strange for people who work in prison to know that the response of prisoners is higher than in the community, because we have the prisoner there in their cells. So we don't need, as in the community, to roll up and to ask to come to us to be vaccinated. So if it is good organized, you can reach very high results, as you did. Another consideration, and afterwards I would like to have your comment, of course. The sample you give us could be representative from the national situation or not. And the model you would like to apply, so the so-called gold standard, can be applied in every prison. It's also something to be considered, because if you want to promote a model, the model should be applied in a large part of our prisons. And I would mention the possibility to enroll people when they come into prison and to assess their vaccination status, because offering a packages of intervention with an opt-out strategy, and to know the vaccination status and then to provide them the schedule as you want, tailored, non-tailored. It is right what you say, but we have to take into account that we should make it as easy as possible in prison. So to tailor is something that is very different to the fixed intervention or the fixed schedule. Could be more challenging to tailor intervention. So a comment from you from all of this.
Okay, I'm starting to try to answer to some of your questions. First one, you are right. It's easier to vaccinate people that are detained in prison, but they can refuse, and they refused. So this is the first point. So it's not so obvious that people staying in vaccination they can accept. Marianna was telling that in the first period they were refusing a lot, and also now they are refusing for a lot of reasons. I just wanted to underline the importance of working on trust for the medical staff with people living in prison. I've not understood which sample you were referring, but I have showed only the official number that are of all at national level for Italy, for example. Those are all the numbers given by the Ministry of Justice every week. I think they update this data. Talking about tailoring or not tailoring, I understand this is quite difficult. I understand also that we have to understand, we have to agree which are our priorities. But here we are an international consortium working at very high level. I think that we cannot just accept to very easy fix solution, but we have to think about quality, acceptance, and also personalization if we need. We start from the very beginning. I can tell you that the core standard, the minimum standard that we have suggested is something that all countries joining the consortium can achieve, because we have checked which are the vaccination present in that are given in the countries. And if you are asking about Italy, this is also very interesting. To me, it's quite normal that those vaccinations should be given. If they are not giving yet, it's something that has to be discussed because it's a public health problem. It's not that it's something that they cannot do. So this was the idea of talking about standard, gold standard, minimum standard, tailorization. It's just a suggestion, and I think it's a good starting point also for the working group in the afternoon. I don't know if you want to add something, Sarah.
No, what I want to mention is I see two points to proposing this standard. One is the operational point, so what we can really achieve. And the other one is the somehow the advocacy that this project in the end will want to arise. So I think that even if we will not achieve the minimum standard in all the countries participating, it's important as a European project to arise the awareness that that should be the minimum standard.
It's the reason people suggest standard. I think that.
Okay.
There are other questions from the floor. Please.
Thank you very much. It was very interesting. I have some question and one comment. The question is related to the vaccine. You never mentioned polio. So there is a reason for. And the second question is, for migrants, we are trying to push for having as a standard the same vaccine as in the national calendar. So having the same as the general population. So there is reason why you choose to go for minimum and without mentioning the national calendars. These are the two questions, and obviously there are many interesting things, but one especially that I picked up because it's the same as for migrants, very, very similar for migrants, the importance of the registry and having registry connected with the general population and not separate, and that and the denominator of, because we never, also for migrants, especially newly arrived, have the denominator for assessing the coverage. So really this is, and if COVID-19 has made it possible to have this, we have to push and say, why not having for all the other vaccination? Thank you very much.
Okay, yes, polio should be there with tetanus. Is something that we have not put at this very beginning talking about this standard. So I'm very glad that you are asking about migrant population. So the point is that we are stressing the point that we want to increase the connection with the territorial medicine. And of course, this is something that I didn't tell before, but the tool that we are building with Davide should also, how to say, be able to interconnect with the official tools that in Italy are, for example, collecting data about vaccination in the population. So this is something that is already difficult to make, because every time you have to do the double of work, because you are building your own database and then you have to refill the database of the official tools that are not talking together very, very, very smoothly. About the denominator of the migrant population, unfortunately, this is not something that the COVID vaccination have solved, of course. You know better than me. It's true that the COVID vaccination, after struggles, we managed also to give to migrants, and there were a lot of problems for the COVID certificates for migrants. So this is something that is still there. I don't know if Ruggero wants to add something about the migrant situation. We don't have further tools to face this situation.
No, I mean, I think the problem with migrant, I mean, is a problem in terms of not, I mean, starting from identification, starting from, the capacity also to access, vaccination in a person just arrived in the prison. I mean, there are many challenges, also with the cultural aspect of vaccination. It's true that the coverage for some vaccine is very high in many countries in the world, but still the people that we are meeting, are... So I think, I mean, not always, are represent or can be just the, the excluded part also in their own country. So I think this is quite a challenge, especially vaccination in migrant. I think is an issue that we need to. So I think.
Before I forget, but it's very important that the prison probably is one of the few places in our country where you are giving the same vaccination schedule of the general population. So this is something that is going to equiparate them, because we are assessing, for example, the hepatitis B status for all people living in prison, and we are giving the vaccination for those who have not. And the same we should do also for measles, I think. For in the juvenile prison of Beccaria, we do all the serological test, and a lot of young people in Beccaria prison are foreigners. And so it's a way to level up a bit. Of course, it's a very small part of the migrant population in prison, but it is something that is working towards that direction.
On this, if I may ask to Filippa, on this, and how what are from WHO perspective the thinking. I mean, what we are saying here that we need to put together with the epidemiology and also the origin of the people in prison, together with the screening, both coverage and result, and link this with the vaccination activity. So I think it's quite a big challenge to link all this information together. And the next challenge that I ask is, how to make the interoperability with the community service. That I think is one of the issue here that people are reporting.
Thank you. Thank you. Yes. In terms of interoperability of the systems, I don't have the answer for your problem. So I didn't show that part of the data, but Lara was asking that also. In most countries, during the admission process, there's quite a good evaluation and exhaustive of immunization status, behaviors, everything. And it's all being recorded somewhere, but then it's not possible to extract. So in most countries, we know that they have, for example, they collect data if the person smokes, let's say. But then we ask, so how many people smoke in your prison? And they cannot know. So it's not just the fact that it's not interoperable, but it's also the fact that it's not possible to extract the data. So yes, I think the only possibility, it would be to involve the ministries that are responsible for the health information system in the country, because that will vary, and they would be the ones to need to create a solution, because it will vary by country. So it's a lot of policy work, I imagine. You all, yeah, good luck.
Just one on, thank you, Filippa, also, and thank you, Ruggero, for raising this point, which is quite important, as we've seen also in the presentations. I'd like to perhaps ask to Martin whether this is some, as you mentioned earlier this morning, that there's a new plan from Commission, right, to create this health platform for sharing and, I mean, collecting and sharing health information of European citizens. And I was thinking now that Filippa was raising this as an issue, of course, for ministers of health in different countries, or Ministry of Interior or Justice, depending on the organization. But would this be perhaps taken into consideration in European and EU or DigiSante plan going forward on this health platform?
Like this, that's better. I mean, I don't want to sound pessimistic, but I think there's still a long way to go, because for this new European health data space, this is basically it's a system for the exchange of health records and e-prescriptions, and also something called patient summaries, which is basically a shorter version of an e-health record. And then, I mean, the new thing is, because that already existed actually, the new thing with this system is basically that the patient or the individual itself will have more access to its own health data. But this is a system that is kind of, at least as I'm not working on this directly, but I imagine that this is some sort of overall more generic system. And I do not think that, because when you speak about registration of vaccines and vaccinations, I think of immunization information systems, and they are very different in member states. Some of them are super advanced. They can do basically, they both have some sort of interface where citizens themselves can follow their status, but they also have another more what should we, a more like back office, so that health professionals can see what the status is, such things. But even in countries with less advanced, well, already now some countries do have less advanced it's so difficult. Immunization information systems, they're less advanced in some countries, and as far as I understand, in some countries there's not even a link between the regional level and the national level. So I could imagine very well that it is a problem to have this exchange between, for instance, a prison and the regional or national level. And I do not think that this will be improved with our new system. But of course, I mean, in the new system, which is basically already there, the new thing, as I said, is more about empowerment of people. There are some hooks so that vaccination can play a more prominent part. But in a way, it is more for the general population as such. It's about continuity of care when traveling around. So I would say it's good news, but maybe not yet for the prison population. Sorry for that.
Not a question, perhaps a suggestion to the RISE-Vac project and also to the European Commission. I think we have to take into the consideration what we have in this moment as referring to the COVID vaccination. In some countries, for example, in Romania, where I am, I have the EU digital certificate on my vaccination. So there is a platform on the vaccination. In my country, the proportion of migrants, so those who have not that ID identification necessary to enter in this platform, do you know, as the general population, they are not in prison. They are quite short number. So European Commission has or may have and should have the data on the COVID vaccination from this platform. On the other hand, EU has given money for COVID for all the countries. So this platform can be implemented, a kind of this platform, at least for COVID vaccination in all the EU countries, yes, even they are not very rich. And the other health registry electronic is not in place, do you know, and the connection and interoperability. But in matter of COVID, the interoperability can be much easier because of these platforms. So what will have the Western countries in related with the migrant population? They could and may have the data from this platform if it is in place in the Eastern countries, Romania, Poland, Hungary, Bulgaria, and Balkanic countries. Now, if we have this platform for the COVID, at least for vaccination, it's a suggestion. We can, or you can, extend, do you know, to other, if possible, to other vaccinations, but at least in COVID, it is feasible in my point of view. Thank you.
Thank you very much for that question. You're right and you're wrong. I mean, there is a platform, and it's a platform that can be used by all countries. It does not depend on your immunization information system. That's for sure. The problem is that the EU COVID-19 digital certificate is based on a legal basis that has to do with free movement. We do not have the same legal basis in health. So, and now I need to be careful, if we want such a card with other vaccines than the COVID-19 vaccination, we would need to base this on our health legal mandate. The legal mandate in health is so far only that the Commission can play a supportive and coordinating role. That would require that all the member states agreed that there should be such a common EU vaccination card. We do not currently think that the time is mature for such a proposal, because for the moment being, people have learned basically that COVID-19 vaccination is a prerequisite for traveling. And we cannot have such a mandate for other vaccines. I'm not saying that this will never happen, and you're completely right that the structure as such, and again, I'm not a specialist, but the structure as such was easy to implement. It's a software that can be used. But the other thing about including more vaccines, then you have the whole problem that the countries do not agree on the vaccination schedule. That's one thing. But the other problem is simply that we would need countries to agree on this. And we would also need to politically stress that, yes, you would have such a vaccination card, but it would only be something that you could use to follow up on your own health or for your health professional to look after. But we cannot mix the message with the one for COVID-19, where COVID-19 vaccination was for you to be able to travel. Do you see what I mean? This is why it's super sensitive. And I mean, I would like such a solution because I'm completely pro. But the thing is that it's very, very sensitive for the moment being, because of the very good solution that the COVID-19 digital certificate was for traveling. I hope that it's super complicated, and I'm sorry that I cannot explain better, but I hope this is sufficient. Thank you.
Many points were touched during this section. Unfortunately, time is running and we have to move on. We have the lunch that is waiting for us. I hope we can discuss, informally during lunch break, some of these points that were raised. We discussed about strategy, data collections, and we can close the section here.
Let's move to the lunch offered by the women of San Vittore. The weather is quite fine. They have prepared the lunch outdoors in the detention area. So I have to ask you to leave out your mobile and any other electronic device. We will collect them and then return after the tour. The tour of San Vittore will start after the lunch. I have to ask you to advise you that any interview with detainees is not allowed by penitentiary administrations. I know that two of you are vegetarian. We have arranged 2 vegetarian meals, either for dinner, for lunch, and for dinner, for tonight dinner. I think there is any.
We are collecting the mobile there.
Each of you knows your assignment group for the tour. The first group, the leader, Teresa Sebastiani. The second group, Ruggero Giuliani. You received the mail with your assignment group. You know? Each of you know? Maybe we can... ok. Lo possiamo proiettare? Ok. Oppure c'è un foglio. Ok. No, direttamente dal pranzo perché già all'interno, grazie. Se me c'è l'elenco, c'è un elenco. Io però le devo mandare.
No? Can we leave the mobile?
Yeah.
We will collect them. Yeah.
To leave them in
Okay,
the bag?
Yeah, you can leave your mobile
The room is closed.
there at the back or in your bag. And the visit will start directly after lunch. So we're not coming back here. So that's why we ask you to leave all your stuff here now. Thank you.